Good morning, good afternoon, good evening, all, depending on wherever from the globe you are joining in. I am Kaustubh Jog, a psychiatrist and a senior research fellow at the Center for Mental Health Law and Policy, Indian Law Society, Pune. On behalf of the organizers and co-hosts, I welcome you all to the opening day of the 9th National Bioethics Conference and 5th Global Mental Health Summit 2022. The Forum for Medical Ethics Society hosts the National Bioethics Conference every 2 years. The aim of the conference is to foster dialogue and debate on critical ethical issues in global health while maintaining an intersectoral and interdisciplinary lens to these discussions. The Movement for Global Mental Health organized 4 Global Mental Health Summit previously. MGMH is a network of individuals and organizations that aim to improve services for people living with mental health problems and psychosocial disabilities worldwide, especially in low and middle income countries. This year, the conference is in hybrid format with day 1 and day 2, which is 3rd December and 10th December being organized online, and third day on 17th December, conference will be in person at Chennai, India. This conference is being co-hosted by Forum for Medical Ethics Society and Indian Journal Medical Ethics, Movement for Global Mental Health, and Banyan Academy of Leadership in Mental Health, Center for Mental Health Law and Policy, and Sangat. The main theme of this conference is mental health, center staging, human rights, ethics, law, and policy. The theme focuses on advancing knowledge and broadening perspectives on mental health, which are founded on core ethical principles of individual and societal well-being, and rights-based and equitable care for all. We invite interest and contributions that question existing paradigms and investigate critical problems that impede progress in the mental health care system globally, and offer solutions to achieve improved outcomes at both an individual and systemic levels. Our conference program has been curated keeping in mind that there are perspectives that are neglected and need to be heard, that there is a need to meaningfully involve diverse and representative stakeholders. We anticipate that the conference will provide an opportunity for service users, families, practitioners, implementers, academics, policymakers, and various other actors to influence the agenda for ethics and mental health. Today's sub-theme for the conference is changing paradigms in mental health care. We all believe and know that it is extremely important to promote and protect rights of people with mental health conditions by changing existing paradigms in mental health care, which is still dominated by reductionist biomedical model. We know that biomedical model has contributed to exclusion, neglect, coercion, and abuse of people with various mental health conditions. And that is why there is a need to discuss more and more about social, political, economic aspects of mental health conditions or psychosocial disability. It is important that people with mental health condition should attain full autonomy and free choice to choose their recovery pathway. Thereby, gradually, we can decentralize power dynamics in mental health care system. Similarly, we should bring equity in mental health care by addressing systemic and structural barriers like gender, race, ethnicity, caste, poverty, and so on. And for this to happen, we need active and constructive dialogue to push the needle forward towards rights-based framework for mental health care. On behalf of organizers, we hope that this conference will bring that push towards the rights-based framework for mental health care. So with this brief introduction, let us begin with our first sessions of the day, which is a keynote address on social justice and global mental health by Rochelle Burgess. Before I introduce today's keynote speaker, there is one housekeeping note for all attendees. Please enter your questions or comments in the Q&A box, which will be visible at the bottom of your screen. The facilitator or moderator of that session will take up these questions or comments to relevant speakers. Thank you. Now I welcome Rochelle. Thank you very much, Rochelle, for agreeing to deliver a keynote address for this conference. I will do a brief introduction of Rochelle and then hand it over to her. Dr. Rochelle Burgess is a community health psychologist and scholar activist based at University College London. Her work grounded in promotion of community-led actions for health improvements through the promotion of health-enabling environments. She is interested in socio-political economy of health improvement and the role of social movements in health and health systems improvement. She has worked alongside community, NGO, and activist groups in the UK, South Africa, Zimbabwe, and Colombia on mental health improvements for the last decade. Rochelle is an associate professor in global health and deputy director of the UCL Center for Global Non-Communicable Diseases at the Institute for Global Health at UCL. She is the founder and director of UCL's Global Network on Mental Health and Child Marriage. She is fellow of Royal Society of Public Health, member of ECRC Peer Review College, UK Trauma Council, among other affiliations. I will now hand it over to Rochelle.
Thank you so much for having me. It's a real pleasure and an honor to be here today at such an important conference, which is trying to do something so important for our field. It's morning here in the UK. The sun is theoretically up. If you see a blanket, it's because also it's the winter, so I'm a bit cold, much colder than those joining us from India today. I think one of the reasons I'm so excited about having the opportunity to speak today is, as a community psychologist, it's a discipline that is really rooted in trying to drive interdisciplinary alliances with the purpose and the aim of trying to broaden the ways in which we define what counts as health, what it means to be a good life, and what is the possibility for good health in the reality when realities are so difficult for so many. So my talk today is titled "First Justice, Then Hope: A Socio-Political Economy to Achieve Mental Health for All." So next slide, please.
Yeah. I'm just sharing the screen, Rochelle, sorry.
Okay. Oh, great. Wonderful, thanks. So if we can go to the second slide, that would be great. Perfect, thank you. So as we've already heard this morning, the movement for global mental health has been working for some time to try and address one of the largest challenges I think that the mental health field faces, which is the gap between those who are in need of supports and those who and the ability or availability of supports and services. And it will be of no surprise, I think, to many people on this call today that the movement has faced much critique over the mechanisms and pathways through which this treatment gap has been addressed. And I think one of the main reasons that this critique has emerged is linked to the spaces and the ways in which services reflect or engage with the needs of communities and service users on the ground, particularly in resource-poor settings. At the end of his tenure as Special Rapporteur for the Achievement of Health and Wellbeing for All, Rapporteur Porras in 2020 wrote his final report. And in that final report, he reflected significantly on mental health as a concern. And he made a very interesting and very powerful statement that has fit in and responds to a lot of the critiques that many have seen and myself and other colleagues such as myself, in terms of the paradigms that we are trying to mobilize for alternative frameworks for care. And in this sort of quote that's on this screen, you sort of really highlight that the limitation to these methodologies has been that a focus on individual services rather than on the environments that drive poor mental health or the poverty and social injustice that is often at the heart of much mental distress around the world has not been the way in which we focus on support. And this is not essentially the most effective way to achieve a human rights-based approach. And the reason for that is because it has a very narrow view of human rights, in the sense that we think about only the right to treatment within this framework of human rights. And if we know and think about human rights more broadly, perhaps in a Amartya Sen framework of sort of the right to key freedoms that enable people to live a good life, then what is required for good mental health services must change. Next slide, please. So the movement is no stranger to an acknowledgement of these difficulties, at least in some parts. So I think what the movement has done quite well is try to illuminate the importance of social determinants to the experience of good mental health. On the slide is an image developed by the work of Professor Crick Lund and colleagues, trying to make sense of the relationship between poverty and poor mental ill health. And I think what this figure allows us to do is it's sort of driven a lot of powerful acknowledgement of this cycle that moves between the experience and the lived reality of poverty and associated factors such as economic deprivation, unemployment, and lack of basic amenities to the development of poor mental health. So some of the pathways that have been identified in the evidence include social exclusion, reduced access to social capital, violence and trauma, which are all factors that we know are very much related to the experience of poor mental ill health, particularly common mental health disorders. And the alternative pathway to that is that once people then fall into the experiences of mental health conditions, they are more likely then to experience factors that drive them into poverty. So all over the world, we know that mental health conditions often result in increased health expenditures. The high levels of stigma might result in loss of employment and isolation within communities and societies. And so that means that people with mental health conditions are more likely to fall into poverty. And some evidence from various parts in the world, including South Africa, shows us that once you are in this cycle, it is much harder to get out of it. And so I think one of the big takeaways from this understanding is that we need to be thinking about the spaces where mental health is lived, that mental health is very much determined by societies. And if we are only thinking about treatment as one aspect of how we give people pathways to better mental health, then we are ultimately missing a big chunk of the puzzle. Next slide, please. And if we just take one region in the world to think about this, we can sort of see that actually we need to be, if we're thinking about society, that actually requires us to move the needle a bit and thinking deeply and more intimately about what are the factors in our social worlds that are driving poor mental health outcomes, and embedding people and locking people into cycles of poor mental health and sort of wider societal struggle. And the COVID-19 pandemic really offered us an opportunity for many of these dimensions to be illuminated in I think what was very much a novelty for people working in the mental health field. We saw within the pandemic that almost immediately there was an interest in mental health care and mental health needs. And for those who have been around and working in the field during other sort of emergent pandemics or crises, the mental health needs and mental health interests action in those areas lagged for some time, as we saw in the spaces of HIV, for example. But there was much discussion about this in the pandemic right from the get-go. And I just want to take one sort of focus on one region. I'm going to be showing you some stats from the Western Pacific region, and to really sort of try and make sense of some of the different ways we can think about sort of these wider social challenges and their relations to poor mental health. So Pacific Island regions in sort of recent years have been identified as having highest rates of suicide in the Western Pacific. And this is largely attached to younger populations and Indigenous populations. And I think that we're seeing particularly in this space and in that phenomenon is the ways in which opportunities for young people are restricted in sort of our current social landscape, and sort of long-term erasures and violences facing many Indigenous populations in the region, but also around the world, continue to be a huge risk factor for poor mental health outcomes and death by suicide in this particular case. If we look specifically at the pandemic in the region, border closures and other sort of shocks created issues that create increased food insecurity and sort of reductions in the economy of around 8%. That was equated to around $2 billion US. And so when you think about what that restriction and that constriction of funds and resources does, it sort of gives us a sort of a relationship to sort of how we think about different interventions or supports that might have been funded by aid feed into the high risk groups in the sort of for death by suicide category. In terms of thinking about climate change, we know that small island developing states are particularly exposed to climate crisis and extreme weather events. And we know that there's increasing evidence showing us that these dynamics have associated mental health impacts, both from the event itself, where we see sort of increased experiences of anxiety, post-traumatic stress conditions, and other sort of distress. But we also know about sort of experiences of climate anxiety, sort of that becomes widespread amongst communities who are exposed and have very little recourse for protection. If you could just advance the cursor one more time. Thank you. And then the pandemic also illuminated the importance of thinking about sort of long-standing risk factors that exist for many people around the world. And one of these was violence against women. As we engaged in and employed lockdown tactics to try and reduce the spread of the virus, we knew that there were increasing rates and increasing exposure for some women and partners and people to experiences of violence. And in regions of the world where these rates of violence were already high, then we know that increased risk would be that much more problematic. And there is this sort of longstanding evidence that shows the relationship between exposure to intimate partner violence and the experience of trauma and mental health conditions. So in this sort of slide, we really see that we're talking about much more than poverty, and our pathways and our interventions and our frameworks really have not advanced as, I think, quickly as they need to, and allowed us to make sense of these different social factors and their direct relationships to the experience and the maintenance of poor mental health outcomes in people's lives. Next slide, please. And I think one of the difficulties for me as I suppose a critical scholar and a scholar activist working in the field is that when we saw the activity and the actions increasing around mental health supports and promotion around the pandemic, a lot of it remained very individual in focus. Individualistic, thinking about increasing access to information, increasing sort of services, maybe through online supports or telephone hotlines, thinking about the individual. And this did not touch the sides of these sort of wider social structural factors that we know would be driving the experience of both acute and actually quite long-term struggles with mental health. And ultimately, in a piece that I wrote in 2020, sort of midway through the pandemic, really argued that unless we are thinking about these wider social realities, then we don't have a hope of sustaining or developing good mental health during the crisis or after. And if we're trying to think about a different future for mental health, one that is really able to think about mental health needs in the short and long term, we have to be thinking socio-structurally. We have to be thinking politically, because a lot of these different social factors are embedded and shaped by different social and political environments at national and transnational levels. Next slide, please. So in order to do that, I think we need to do two things. And the rest of this talk will be devoted to exploring sort of two broad ideas. Advance, please. The first is that we need to change our definition. I think in working with a social determinants model, what we have ended up doing is paying attention to some important factors, but not thinking about where these factors come from, how they become embedded in people's lives, and how they become entrenched in people's lives. And so can we move the needle to also expand our thinking on the social determinants to thinking about what is sometimes called the causes of the causes, and to do so in ways that actually illuminate the different mechanisms that bring these challenges into people's lives. And as part of that, myself, along with colleagues, including Sumitra, I'm not sure if he is on the call today, and Crick London and others, have started to think through what a socio-political economy for global mental health could look like and should look like. Advance the slide one more time, please. And then the second thing I want to talk about is if we use this as a definition or a way of thinking through where mental health challenges come from and how they manifest in people's lives in practical and real terms, it means that we might need to change our responses. And it requires us to do something that I have been talking about since very early in my career. So, one of the first things that I wrote was talking about the importance of building mental health enabling societies and having that be an active part of the work for the movement for global mental health. So I'll talk about these two things for the next little while and then open up to questions. Next slide, please. So the work on socio-political economies and political economies have existed for some time, though we are not often talking about it within mental health spaces in low and middle income countries. There is some work from South Africa looking at this specifically with one factor, again, poverty. But ultimately, there is a lot of work to be done in sort of analyzing analytically and practically in this space. And I think this is a way in which we start to a model which might allow us to take these complexities of these wider systemic social challenges and their relationships to mental health with us into the planning spaces for interventions. This is a quote from Ted Schrecker, who is a social scientist who works on the political economy of public health. And he works a lot with the concepts developed by Nancy Krieger, and what he suggests that a political economy does. It allows us to think about the causes of disease in relation to political and economic structures, as well as social ones, including processes, power, and relationships that are contemporary, but also have occurred in the past, really making sure that we are attending to these challenges. Because these are the factors that ultimately shape the conditions where people live, work, and survive. And if we think about mental health as lived, I think the poverty and mental health cycle is a really good way to conceptualize that actually the living of life in fractured social worlds embeds us into these cycles of poor mental health and social struggle. And so if we want to think about sort of health challenges, we also need to think about where these factors that are causing health challenges come from, because that is where a social world is determined, and how survival is either enabled or hindered. Next slide, please. So in our work, we have sort of identified a series of social and political and economic factors that work both contemporarily and historically to help us make sense of where poor health comes from, or where poor mental health comes from. And the key mechanism that we wanted to think about in this model is actually discrimination, because discrimination is the pathway through which these factors sort of create access to, or actually establish sort of social determinants for poor mental health. So, and I think what's really important to think about in a model like this is that the presence of these factors, and this is sort of an initial suggestion of what might be really important for mental health in sort of many low resource settings around the world in sort of the global south and the global north, is that they are compounded. So there is actually an intersectionality between many of these factors. So for example, if we use the example of colonialism, and how colonialism as a historical and contemporary process. Sorry, can you go back one slide, please? Thank you. So as a historical and contemporary process has made it that some groups are more exposed to other factors that drive distress. So for example, it might mean that certain groups live in particular types of neighborhoods that drive poor mental health outcomes. It is sort of, this colonialism or sort of, racism and its manifestations of colonialism in the United States, for example, led to wider political dynamics that sort of shape how housing was distributed in the 50s and 60s, and it created the experience of sort of, and the creation of slums. And so how does that sort of then manifest in people's exposures to poor mental health? And I think this is something that doesn't necessarily occur only in the US. We can see how certain factors around racism or caste also contributes to people's shaping where people live, shaping how people live. And I think what's really important in a model like this is that it keeps our attention on the importance of the political and sort of various policy and policy environments, and how they actually come to shape the presence or absence of particular social determinants. Next slide, please. So in taking a model like that seriously, it means that we also need to make a shift into what counts as the social and global mental health. And so myself, along with Sumit Jain, who I think you'll be hearing from later today, Inge Peterson and Crick Lund in 2019 wrote a piece in Lancet Psychiatry about the need to expand how we think about the social. And we're very good in our interventions so far at thinking about socio-relational factors. So we think a lot about things like social relationships between family members, and when we're increasingly thinking about the involvement of family members in care pathways. We think a lot about social capital and various forms of capital and how that is important for improving good mental health. But we are less effective at thinking about these socio-structural dynamics, many of which feature in a socio-political economy and have really important determining factors for the ability for people to either prevent the development of mental health conditions or live effectively or recover from poor mental health conditions. And so our argument is that we really need to make sure that we are moving the needle to include both of these notions of the social in how we think about and plan for intervention response within health spaces. And this includes treatment as well as prevention and promotion. Next slide, please. And I think one of the challenges in bringing these together, particularly in the space of interventions that are delivered within health spaces, is that we are stuck within mental health paradigms that separate mental health and mental ill health. So we sort of think, or don't separate them. So we think about ultimately good mental health as, you know, these positive dimensions of social well-being, but that they are only present when mental ill health is treated. And what we sort of really need to be doing is actually saying, okay, could we think about mental ill health and mental health as related but separate paradigms? And Corey Keyes, he's a sociologist from the United States, has done a lot of thinking about the way in which we can work with a dual paradigm. And so Corey Keyes suggests that in a model of complete mental health, you have a continuum of mental health, which is either present or absent. So in this notion of flourishing or languishing and languishing, and that deals with all of the positive dimensions of emotional, cognitive, and social well-being, and really thinks about our ability to contribute to and participate meaningfully in society, and feel that society is able to enable a good life for us. And that is related to the experience of mental ill health conditions, which we understand very well through our sort of psychiatric and mainstream psychological pathways and paradigms. And so it means that in this dual pathway, or using a dual pathway or a dual continuum, it opens up an interesting space to think about who are the different actors that we can bring into dialogues about the development of mental health interventions, including interventions that happen within the mental health space, and how do we work to reduce the experience of mental health conditions, as well as increase the experience of good mental health through increasing psychological and social markers of well-being, often through work at these sort of socio-structural dynamics in people's lives. Next slide, please. So what does this mean? It means we need to sort of balance the tables a bit better. So we need to sort of think about complex interventions that maybe within treatment spaces, increase the amount of attention and focus we give to structural realities within our classic psychological and psychiatric treatment. So the emphasis isn't just on the reduction of mental ill health conditions, but promoting good mental health. And within mental health promotion activities, can be thinking about widening our perspective and our approach to include social mobilization that allows us to act on reducing those structural dimensions that might be driving people into poor mental health challenges in the first place. So really taking former rapporteur Porras's statement quite seriously and saying, if the problem is the societies and the worlds that people live in, then mental health promotion activities need to be talking about changing those social worlds. Next slide, please. And so how we do that, there's might actually require that we move towards transformative approaches in global mental health, rather than our traditional approaches for treatment, which focus on dimensions that have been identified as limiting in many critical spaces. This table is taken from community psychology as one discipline that actually drives us to think about the limitations of traditional approaches and individual approaches and some of the challenges that we face. So if we, in traditional approaches, we focus on problems which can be individualized, identifying people's deficits and symptom challenges as the main focus of our intervention, and then reducing those maladaptive behaviors, ensuring compliance with treatments, then one of the problems is we miss opportunities to think and act on a much wider range of factors that drive people's health. And so in transformative approaches, what the argument is that we can define the problem in a more complex way. So potentially using frameworks like the socio-political economy to place individuals within context and acknowledge the diversity of those contexts. And the focus of the intervention is not only the identification of a problem, but also identification of people's competence and strengths to cope with those problems, because some people do cope effectively. And how can we think about the promotion of and building of those strengths and the promotion of competency and wellness as a big part of how we deliver, design, and create interventions. And one way that we can sort of do that is to think about interventions as a site to develop community mental health competencies. And this is, again, a framework that I have been talking about for some time, about 10 years now, and really sort of drives us to think about what mental health needs, how to approach mental health needs in more complex ways. Next slide, please. So the competencies framework suggests that mental health interventions, wherever they are situated, whether they are in the community or within sort of the formal health infrastructure, should be thinking of promoting 4 dynamics. The first is knowledge. And so we can think about this in the classic way of exposing people to increased amounts of knowledge about mental health disorders and the importance of referral to specialists, which are things that we do quite well. But one aspect that it tries to increase our attention to is the importance of identifying and deploying Indigenous knowledge. And there's a growing body of research about the certain types of collaborations between traditional healers. But I think we need to really force ourselves to make sure that these dialogues are not one way. And so how do we identify Indigenous knowledge practices that are important to communities, important to people with lived experience, and how do they become packaged within experiences of promoting well-being? And there are a few examples in the literature, I think from Ethiopia, about how this can be used in the context of severe mental illnesses. In terms of the next competency, solidarity and identifying strengths, this is very much about this idea that we aren't just working to identify people's mental ill health conditions, but actually finding ways to develop and illuminate and have people recognize that they have solidarity with others that are experiencing similar experiences. So this might be the experience of the disorder itself, but in taking this a step further, it's also the experience of the social factors that are driving them themselves. Sorry, one slide back. I'm almost done. And then the final 2 are related dynamics. They are thinking about sort of dialogue, so the importance of social spaces where people feel safe to engage in dialogue about their wider context that frame their distress, and the importance of partnerships that take place in those dialogues, understanding and acknowledging that people will need access to different types of resources in order to allow them to not only just respond to their mental health challenges, but to also acknowledge and engage with the wider structural challenges that they face linked to their poor mental health. Next slide, please. So I very quickly want to talk through an example of a type of intervention that I've been involved with in South Africa that gives us an opportunity to build mental health competencies, and that is sort of designed to work and be delivered within a mental health system or within community sites. So next slide, please. In South Africa, very quickly, the socio-political economy that I showed you earlier is a big part of what is driving poor mental health in the context. Burns is one of the authors who has been worked a little bit on, who has worked on the socio-political economy of poverty and its relation to mental health, and really showing us that actually it's this chronicity of poverty and how it links to other social factors that becomes the big problem. And so we need to really be asking ourselves, what is the types of interventions for depression or chronic trauma when there are ongoing structural social challenges in a wider environment? Next slide, please. So along with colleagues at an organization called FOLA, we piloted a project called Courage Plus. Courage Plus is a combination of two pieces. It's a core counseling program which uses collective narrative therapy as a mechanism to sort of focus on the mental ill health dimension. So it involves storytelling and also indigenous frameworks and paradigms around Ubuntu principles to allow, and this is an intervention for women, to allow women to think about their trauma and their mental health challenges and re-story their lives so that they come to think about themselves not just as victims of wider social structural realities, but also as survivors of those frameworks. And sort of how does this enable a process of cognitive reframing? Next slide, please. And the second half of that program is a social development intervention. And so it says that once you've sort of found a way to think through and restore your life, acknowledging the role of the structural and how you have survived it, you need a space to then think about how you might develop an action plan to work in response to these structural realities that will remain in your life and remain a challenge to your mental health and well-being. So can we enable people to focus on planning and responding to the challenges that they identify as critical for their mental health? And this sort of package of sessions happens at the end of that program. They're called booster sessions, and this package includes opportunities to sort of plan. They're trained on a model for planning to sort of like interventions and change interventions that are focused on on their wider society. And they then have an opportunity to do training. So they ask for training from external partners, which the project organizes, and they come in and sort of give them guidance on how to develop and move their projects to the next stage. In this study, they had training on savings programs and starting up a social enterprise. Next slide. So very quickly, this is the sample. We worked with about 50 women, mothers of children with disability in urban and semi-rural communities facing sort of structural realities of poverty, high levels of interpersonal violence, and low levels of social opportunity. And the average age of the women was 37. Next slide, please. And what we wanted to look at from this intervention was the dual continuum. So we wanted to look at, does this intervention reduce mental ill health conditions? So is there a change in the patient health questionnaire, which we use to measure depression? How does it impact on good mental health? So these things about social, psychological, and sociological well-being. And we did that through interviews with women. And what is the impact on the wider society? Is there a change in women's prospects and engagement with their social worlds? So next slide, please. So the intervention was found to be highly successful. 65% of our sample brought their scores down to 0 on the PHQ-9 at the end of the intervention. And I think what's important to say is that we measured the intervention in 2 ways. We first looked at the impact of the counseling intervention and then the additional impact of the booster sessions. And there was significant reductions at both time points. So on its own, the intervention works, and then there's an additional booster added by the addition of this social support and social development package. Next slide, please. Just very quickly allows us to see this across different symptom load groups, showing that whether you started off as severe or more mild in terms of the PHQ-9, there is still a reduction in scores. And we found these to be statistically significant in all of our symptom load groups. Next slide, please. So in terms of women's perspectives on sort of the good mental health pathway, women felt that they were able to identify 4 different dimensions of good mental health. So they said that they were able to recognize purpose in their life. So this is around a mechanism linked to psychological well-being, increased partnerships and the value of friendships linked to their social well-being, and really sort of thinking about their ability to move beyond historical trauma. Next slide, please. And then finally, it was, I think, really important to say that what women did in the groups extended beyond that. So we followed up women after the intervention during the pandemic to sort of see how that type of shock affected them. Women started their savings groups to increase their financial stability, and they collaboratively worked together during the pandemic to address their food insecurity. And there were 2 groups of women who started their own small businesses and social enterprises, following up on their training they received in the intervention. Next slide, please. So ultimately, that intervention gives us an opportunity to build community mental health competencies. It was delivered by psychological or psychosocial counselors, so people from the community, in collaboration with auxiliary social workers, which is a cadre of health professional in South Africa that works both in community and in health settings. And so by seeing the feasibility of this intervention being delivered by those actors, it gives us a picture of the possibility for the intervention to be delivered both in community sites and potentially in health sites. And that's what the next stage of our research will go on to explore. And the bubbles on the right-hand side really give us a chance to look at these markers of psychological and social well-being. So social coherence and social integration are big, important markers for social well-being. So the ability to sort of feel integrated in your community, and environmental mastery, purpose in life, and life satisfaction are markers of psychological well-being that are really important. And our final slide, next slide, please. So ultimately, when we sort of think back to these 2 calls to action, I suppose, that I'm asking for, I think the future of mental health drives us to change our definition. So we're moving beyond poverty to think about structural realities. And when we did that in women's ownership of the Courage intervention, means that they developed interventions that spoke to the specific parts of their environments that were most important to them. And that we were able to restore good mental health by actually restoring stability in women's lives and creating opportunities for hope, by sort of acting in ways that were more oriented to social justice and those structural realities. And it's important, I think, to recognize that interventions, even small, short-term ones, can build the foundations for wider social change. And these types of interventions that think about mental health competencies allow us to work both in the short term for the reduction of mental ill health symptoms and the long term for the promotion of good mental health. And that's it. Thank you very much. I'm possibly over time, but hopefully have enough time for a few more questions.
Thank you very much, Rochelle. That was really great. It was quite to the point. So we have 2 questions in the Q&A section. I can read out.
Yes, please.
Yeah. So the first question is from Aruna. In the context of socio-political economy of mental health, how do we ensure, especially in resource-poor settings, that choice and agency, specifically in seeking care of the person with mental illness, caregivers, and other supporting actors is foregrounded?
Okay, thanks, Aruna. I think that's a really good question. Because one of the challenges we faced in sort of current care frameworks is that even though we have a dialogue, sometimes you can have a dialogue between patients and providers, the package of care is quite formally structured and really only speaks to a small portion of what people are facing. Or if we do acknowledge the social, a lot of times those are referrals, and sort of people are asked to sort of go to different sectors in society. And I think while that is important, the reality of that is that moving between these different sort of social departments and government spaces is often quite difficult, particularly if you have identity linked to a mental illness. So I think what becomes really important to actually achieve and implement a socio-political economy approach is that we need to have two things. We need to sort of have, on one side, different types of training for practitioners, so that practitioners become aware. Practitioners are given space within their practice to sort of really think about and engage with those types of factors beyond the medical. What it means, I think some people talk about changing the ways in which we do diagnostic encounters, moving towards compassionate care models, which actually allow us to sort of change the types of dialogues that we have. But what must go along with that are different packages of interventions. I think there's no point in practitioners becoming well-versed in sort of hearing and engaging with these complexities if then they have nowhere to send people, if they're just sending people to the same types of interventions. And so it means that we really need to scale up the presence of multiple types of interventions that are able to speak to some of these complexities. And I think it means that our interventions need to be designed alongside communities and with communities. So through co-producing different types of interventions, we'll end up with packages of care that are more reflective of what people actually need. And so it's sort of this two levels of action that need to be happening simultaneously. We need practitioners to have opportunities to be trained in different sort of modes of dialogue and engagement with their patients, that open up spaces to talk about these realities. And then we need different types of interventions for them to send their patients to. And so those interventions can be in care centers, so in hospitals, in community, in primary care centers, but they can also be outside of it, so delivered by local NGO partners. And so really thinking about how we widen the remit of who is delivering valuable mental health support programming. And that would be what I would say to that question.
Thanks, that's great, Roshal. So one more question, I think, as I understand, Karishma is trying to ask, in addition to PHQ, how can we measure well-being? Or if there are some other mental health parameters which we can measure? Yeah.
So the PHQ-9 I use as a pretty standard measure for depression, as particularly if I'm doing sort of community level work, because I think that is largely, it's quite a widespread experience of mental health, and I think it picks up a lot. In terms of the sort of social well-being, those measures are a bit more complicated. So in some of my work in Colombia, there are traditional measures for psychological and social well-being developed by Corey Keyes and Carol Riff, actually, but the measures are incredibly long. And so when we tried to use these measures in Colombia, community members rejected them. They just said they just didn't want to do them. They were too long. And so what we're doing in a new study is using the WHO-5 as a well-being measure to try and get us to think a little bit about more of the social parameters. You could also, in some other studies, we could see there is the use of the social capital tools to try and actually measure social well-being. So you can use social capital potentially as a proxy for some of those outcomes within the model. But I think there's lots of scope actually for and we need to really, in the global mental health space, be thinking about creating locally valid measures and locally grounded measures, because what is, because what counts as social well-being and psychological well-being, the content of that will be different everywhere in the world, because it very much attaches to sort of cultural and local framings of what is a good life, this idea of what is a good life for me. And I think if we try to push ourselves too much towards standardized measures, it will lose that complexity. It will lose that. So I think there is a lot of scope to be done, and again, in working with community members, with patients, with families, with everyday citizens, to develop local measures in national and regional contexts, and even sort of like community context. I mean, because if you go nationally in some place like India, actually, I think when you go to each different state, actually, things are very different. So you would actually want to look specifically in areas about what a good life is and try and develop a measure that makes sense to that, because that's what people are often striving towards, and what the experience of poor mental health is bound up in, this need to live a good life. And what a good life means it changes depending where you are.
Thank you. Thank you, Rochelle. With the paucity of time, I think I'm afraid we can't take more questions. We have already next session panelist already there. So I'd like to thank you fully for being there today and delivering this keynote on the behalf of organizers and all the co-hosts. Thank you very much again. We will end this session. I think for all attendees, we will take a 5 minutes break and then we will immediately join in for the next session, which is a panel discussion. Thank you, Roshni.
Thanks.
Okay, thank you. Bye. I hope all of you are back from the break. I know there is a short break, but we should start on time with. We should start in time with the second session. So I'll just try to introduce the moderator for today's session, and then we will start with the panel discussion. This is the second session of the day. It's a panel discussion on mental health, marginalization, and development. We have 4 panelists for this session, and the session will be moderated by Professor Surinder Jaswal. I will introduce Surinder and hand it over to her.
Thank you.
Professor Surinder Jaswal is professor in Center for Health and Mental Health, School of Social Work at Tata Institute of Social Sciences, Mumbai. She is also the Dean of Research and Development and the Associate Editor of the Indian Journal of Social Work. She has MA in Social Work and PhD from London School of Hygiene and Tropical Medicine. Her research interests include health and development, disaster and health, women's health, public health policy, health, ethnic conflict, and qualitative research methods. She has initiated and led several field action projects and has been investigators for over 35 research studies. So with this brief introduction, I would like to hand it over to Surinder. Welcome, Surinder, and first of all, thank you for accepting this invitation for moderating this panel discussion. I hope it will go well. I'm at the background, so I will facilitate the questions after your panel discussion. Yeah, over to you, Surinder.
Thank you. Am I audible, Kaustubh?
Yes, very much.
Yeah, okay. So many thanks, Kaustubh. First and foremost to the organizers for inviting me to moderate today's session. Also, I would like to congratulate both the organizers of the Bioethics Conference as well as the Global Mental Health Summit for bringing together 2 topics which have been at the margins for a very, very long time. And I think the coming together of these 2 topics for today's conference also in a way rings a bell for visibilizing areas which have been marginalized for a very long time. I must tell today's audience that today for the panel discussion on mental health, marginalization and development, we have 4 key leaders, or I would say 4 champions of these domains who will be sharing their thoughts with us. I would like to begin by introducing the 4 of them and also orienting you briefly to the manner in which we will conduct the panel discussion. We have a total of only about 45 minutes, so we are short of time, and I'm going to be a little strict in terms of moderating the session. We will divide the questions into 3 rounds, round 1, 2, and 3, where we will look at some important dimensions of the relationship between mental health, marginalization, and development, particularly to understand the impact of the structural determinants such as caste, race-based discrimination, poverty, gender, and sexuality on mental health and well-being of both individuals and communities at the local to the global level. And we will take in round 2 and 3 a conversation. We'll have a conversation on the potential opportunities and strategies in the form of research, policy, and programmatic interventions for developing equitable societies which center mental health needs of marginalized communities. So as you can see, a very, very interesting domain which we're going to speak about. And the 4 people that I'm going to introduce you today, the panelists for today, we couldn't have selected a better group of people to address these questions. At the outset, I would like to introduce Deepa Pawar, who is the founder director of Anubhuti Trust, which is an anti-caste intersectional feminist organization working to build grassroots leadership towards a more just, equitable, and democratic society. She started working at a very young age when she was an adolescent and has worked on matters of gender, mental health, sexual and reproductive rights, sanitation, leadership, Indian constitutional literacy, and interestingly, history reclaiming and movement building. Deepa belongs to the Gadia Lohar nomadic community and has initiated pioneering work with the NT-DNT communities in Maharashtra. Based on her lived experiences, she has coined the concept of mental justice to respond to the wider social justice aspects of mental health, which is faced by the marginalized communities. Deepa has many accolades. She has received many accolades over the years for her work, some of which are that she's been a Sambad 2020 Fellow. She has also received the SRHM Fellow in the Mentoring Program on Rights and Evidence-Based Knowledge Creation, where she carried out the first ever NT women-led research on sexual and reproductive health rights of NT-DNT women. She's also been a fellow of the Collective Impact Partnership and a Goalkeeper Youth Action Accelerator, and has her initiatives for safe higher education spaces and youth mental health have been recognized internationally. She is the winner of several awards. I will not detail them at this point. I think we will share your bio, Deepa, with our audience so that they can learn a little bit more about you. I will go on to our second speaker. I'm going to introduce all four, and then we will begin the round one or phase one of the questions. Yeah. So the second person that I would like to introduce is an old friend, Dr. Sumit Jain, who's a senior lecturer at the School of Social and Political Science, University of Edinburgh in the UK. He has studied international development at the University of Toronto and social work at McGill University, Montreal, and his doctoral work is from UCL London, University College London. Sumit has teaching interests which focus on culture and mental health in low-income contexts, and mental health and well-being. And he has taught both at the undergraduate and postgraduate level, and is the director for an MSc in the Global Mental Health and Society course, as well as the course organizer for Critical Approaches to Social Change and Global Mental Health. Sumit's research contributes to the improvement of mental health outcomes by drawing on interdisciplinary knowledge and mixed methods. His work unpacks the notion of global mental health and attempts to inform development of services that account for local experiences and understandings of psychological distress. Welcome, Sumit, also to the panel. The third speaker for today is a colleague and someone that I have known over the years, that is Dr. Ketki Ranade, also known as KP. She is currently an assistant professor at the Mumbai campus at the Center for Health and Mental Health School of Social Work. KP is, as I said, a faculty at the center. She has completed her graduation in psychology from Mumbai University, her master's from TIS, and gone on to do her MPhil and PhD from NIMHANS, Bangalore, and ended it again at TIS. Prior to her joining teaching, KP has worked for almost a decade as a mental health service provider, researcher, and activist, and has developed mental health service programs in low-income urban settlements and institutions, such as the Beggars Home and the Family Court in Pune and Mumbai. KP's research, writing, and teaching is in the areas of mental health, law, policy, programs and advocacy, LGBTQIA mental health, clinical social work, and research methodologies. She is the author of 3 different volumes, one, Growing Up Gay, A Critical Psychosocial Perspective, another on queer affirmative counseling practice, a resource book for mental health practitioners in India, and a third on sexual rights of women with psychosocial disabilities, Insights from India. She is a member of several committees and is a visiting faculty, has been a visiting faculty at the University of Gothenburg in Sweden. Welcome, KP, to today's panel. Our fourth panelist for today, I hope I pronounce her name right, is Hoa Ojefo, who publicly identifies as a person who lives with a mental health condition and psychosocial disability. Popularly tagged as the voice and face of mental health in Nigeria, Hoa has received numerous local and international honors and recognition. She is the executive director of She Writes Women, also called as SWW, an award-winning movement that gives mental health a voice in Nigeria. She's the creator of Safe Place Nigeria, a virtual community for mental health conscious Nigerians to access digital mental health care, self-care tools, and wellness resources. Hua has also received numerous awards for the work that she has done. I would like to mention a couple of the recognitions. Mentioning all of them will take up the time where we would like to hear her speak today. Two things that I would like to speak about are she's the first African to bag the MTV Generation Change Award and has also been honored as an Obama Africa Leader in 2019. She has also addressed the One Young World delegation at The Hague, Netherlands, and addressed the first ever United Nations Sexual Violence Survivors Town Hall, calling on world leaders to pass a UN Sexual Violence Survivors Bill of Rights. And she has been the first person with a mental health condition to testify before Nigeria's parliament on the inclusion of persons with mental health conditions and psychosocial disabilities in Nigeria's mental health legislative efforts. So friends, as you can see, we have 4 champions of mental health who have contributed to the field of mental health marginalization and development over the last few decades in various ways. We have a good mix of both Indian and people who come from other countries who share their experiences from across the globe, and a good mix of academics and interventionists. So as I said earlier, we're going to have 3 rounds of questions. In the first one, we're going to talk much more about the impact of structural determinants on mental health marginalization and development. And I will read out the questions to each person and they could answer. Each person will get about 3 to 4 minutes to respond to that question before we move on to the second panelist, third, and then the fourth, hoping to finish in 15 minutes round 1, and similarly round 2 and round 3. Okay, it's going to be a tough order, particularly given the body of work that all of you have, but let us try and maybe whet our audience's appetite, and then they can get in touch with you later for more work. So Deepa, I would like to begin with you. Your work with marginalized communities such as the DNT and other oppressed caste communities has focused on mental health and social justice. Drawing on your experiences and engagement with this community, could you tell us about the impact of structural discrimination on the mental health and well-being of individuals and communities, especially in the context that you have worked in?
Yes. जय भीम, जिंदाबाद सबको। मैं हिंदी में बात करूंगी, ट्रांसलेशन के लिए हमारे साथी है वो हेल्प कर देंगे। तो मेरे ओरिएंटेशन में जैसे कहा कि मेरे लिव्ड एक्सपीरियंस जो है वो नोमैडिक ट्राइब कम्युनिटी से है, और मेरा काम का जो भी ढांचा है वो भी ट्राइबल, नोमैडिक ट्राइब, असंगठित कामगार, विस्थापित समूह, जॉबलेस, एम्प्लॉयमेंटलेस, काफी डिस्ट्रेस में रहने वाले जो समूह है, जिनका डिस्ट्रेस का कारण कई बार वो खुद नहीं है, ऐसे समूह के साथ जो है चलता है। जब मैं सोचती हूँ कि सिस्टमैटिकल डिस्क्रिमिनेशन इसका परिणाम क्या है ऐसे समूह पे, तो मुझे रूट लगता है कि सिस्टमैटिकल डिस्क्रिमिनेशन सबसे पहले करता क्या है। सिस्टमैटिकल डिस्क्रिमिनेशन सबसे पहले करता है कि वो इस तरह का नजरिया विकसित करता है, उससे निकलने वाला व्यवहार, बर्ताव, सुविधाएं या रिलेशनशिप, ये कई बार जो अपेक्षा है या गुंजाइश है कि जहाँ पे वो बहुत ज्यादा गैर बराबरी के ऊपर आधारित है, वो भागीदारी को जगह नहीं देता है, वो लोगों के सहभाग और नेतृत्व की जो जगह है वो बहुत कम कर देता है। और जब मैं ये पूरे ढांचे को देखती हूँ, जिसके रूट कॉज जो है वो सत्ता समूह से आते हैं, वर्चस्ववाद से आते हैं, रिग्रेसिव मैस्कुलिनिटी से आते हैं, ब्राह्मणिकल पेट्रियार्की से आते हैं, पुरुष प्रधानता, और कई अंगों में जो भेद की व्यवस्था हमने निर्माण की है, जो भेदभाव की जो व्यवस्था निर्माण की गई है सदियों से, उसका हिस्टोरिकल इम्पैक्ट भी है जो अभी वर्तमान और लोगों के आने वाले भविष्य के ऊपर भी असर करने वाला है। इसके कुछ अगर 4-5 मुद्दे अगर मेरे सामने आते हैं, मुझे एक बहुत नजदीकी के साथ लगता है कि क्या करता है संरचनात्मक भेदभाव की व्यवस्था। सिस्टमैटिकल डिस्क्रिमिनेशन लोगों को सोशल गट्स और डेयर से परहेज करता है, जहां पे वो डिमांड कर पाए, अपनी सूचनाएं दे पाए, वो विरोध कर पाए, वो अपनी आवाजें और अपनी बातें बहुत स्ट्रांगली और कॉन्फिडेंस से रख पाए, ऐसी मुमकिन जगहें वो खारिज कर देता है, वो रद्द कर देता है, वो बनाना बंद कर देता है। उनको वो निर्णय की प्रक्रिया में नहीं लेता है। जो समूह इस तरह के वंचित और दुर्लक्षित समूह से आ रहे हैं, उनकी 2-3 तरह की लड़ाइयाँ हैं। उनकी अंदरूनी भी लड़ाइयाँ हैं, उनकी बाहरी भी लड़ाइयाँ हैं। तो उनकी लड़ाई के जो सामर्थ्य है, लड़ाई लड़ने के लिए जो संसाधन चाहिए, जो सामर्थ्य चाहिए, वहाँ पे वो बहुत पॉइजनिंग एटीट्यूड से उनकी ताकतें कम करता है। और ये सारी चीजें जो है वो अकेले-अकेले नहीं होती है, ये आइसोलेटेड नहीं चलती है। एक ही जगह पे बेसिक नीड से जुड़ी हुई, फिर पानी हो, गटार हो, राशन हो, हेल्थ हो, एजुकेशन हो, ऐसे बेसिक डॉक्यूमेंट हो, ऐसे बेसिक चीजों के लिए बियॉन्ड कैपेसिटी जाकर जब ताकत लगानी पड़ती है, अपनी क्षमता से बाहर जाकर जब ताकत लगानी पड़ती है, वो संघर्षों से जब जूझना पड़ता है, ऐसे हालातों में हम कल्पना कर सकते हैं कि लोग जिस डिस्ट्रेस का सामना करते हैं, वो कई बार उनको उनके ट्रस्ट इश्यू तैयार करता है, उनको डिस्ट्रेस में लेके जाता है, उनको लोनलीनेस में लेके जाता है। एक कमतर होने की भावनाओं का निर्माण उनके भीतर वो करवाता है। और ये कमतर होने की जो भावना है, वो बस वो इंडिविजुअल नहीं है, वो सामूहिक नैरेटिव से, ग्रुप और कम्युनिटी नैरेटिव से निर्माण करता है। और इसके कई कई सारे असर हमें देखने मिलेंगे कि कई बार जो ये कम्युनिटी है, वो अपने इतिहास को जो है देखने की बजाय दूसरे इतिहास के इंजेक्शन इनके अंदर जो है इन्फ्लुएंस किए जाते हैं। जब मैं ये सारी चीजें देखती हूँ कि बहुत बड़ी पैमाने पर रिसोर्सलेस होना, बहुत बड़े पैमाने पर पावरलेस होना, लैंडलेस होना और लैंडलेस होना अपने आप में हर जगह से सत्ताहीन होने का सबूत होता है। तो जब हम नोमैडिक डिनोटिफाइड ट्राइब की बात करें, आदिवासी समूह की बात करें, ग्रामीण असंगठित क्षेत्रों में जुड़े हुए लोगों की बात करें, तो मुझे लगता है कि वो व्यक्तिगत तौर पर, सामूहिक तौर पर जो नजरिया, बर्ताव, व्यवहार लोगों तक पहुंचाता है, वो बहुत ही घिनौने आधार पर पहुंचाता है। वो लोगों की कॉन्स्टिट्यूशन एक्सेसिबिलिटी रोक देता है। वो लोगों को ह्यूमन राइट की एक्सेसिबिलिटी, उपलब्धि प्राप्ति रोक कर बहुत सेटल वे में, छुपे तरीके से और कभी खुले तरीके से लोगों के सामाजिक असुरक्षितता के माहौल तैयार करता है, सोशल इनसिक्योरिटी के माहौल तैयार करता है। और मैं आपको ये पूछती हूँ कि जब लोग इतने सारे संघर्षग्रस्त व्यवस्था में रहेंगे, जहाँ पे वो बात नहीं कर सकते हैं, जहाँ पे वो डिमांड रिकमेंडेशन करने की जगह सीमित की जाए, उसी वक्त उनको बेसिक नीड के लिए बहुत बड़े संघर्ष करने हैं। उसी वक्त सामाजिक असुरक्षितता जो है उससे उनको झुलसना है। उसी वक्त होने वाले पॉलिटिकल बड़े-बड़े डिसीजन, डिजास्टर जैसे कोरोना है, पॉलिटिकल डिसीजन जो कभी अचानक रात के 8:30 बजे हो जाते हैं, इसका जो कॉम्पैक्ट इम्पैक्ट होता है इस कम्युनिटी पर, वो कल्पना शक्ति के बाहर है। वो बहुत ज्यादा जख्में तैयार करता है, इंजरीज तैयार करता है इस तरह के डिप्राइव्ड कम्युनिटी में, मार्जिनलाइज कम्युनिटी के भीतर, कि वो समाज की मुख्य रफ्तार से हमेशा अपने आप को बाहर रखे। और इसका डायरेक्ट इम्पैक्ट जो है वो उनकी मेंटल डिग्निटी के ऊपर है, उनके मेंटल एम्पावरमेंट के ऊपर है। मैं लास्ट कहूंगी कि सिस्टमेटिकल डिस्क्रिमिनेशन सबसे पहले जो अटैक करता है, वो मार्जिनलाइज कम्युनिटी के मेंटल डिग्निटी और मेंटल पावर के ऊपर ही अटैक करता है, क्योंकि उसको बाकी की हिंसा करने के लिए रास्ते तैयार हो। थैंक यू।
Thank you, Deepa. I think very well put in a very concise manner, an extremely complex area. NTDNT is a group which is increasingly coming today into our visible spaces, and I think, but not so much in the field of mental health, and your work is really laudable. We will come back. Sumit, I'll address the first question of round 1 to you. Based on existing research, what do we know about the relationship between mental health and marginality? And building on Deepa's point, can you also tell us about some of your research findings analyzing the linkages between caste, discrimination, and psychological distress in the Indian context?
Thanks very much, Surinder. Can you hear me okay?
Yes, very clear.
Great, thank you. And it's really nice to be here. It's nice to see some familiar faces. In terms of and please do stop me, Surinder, if I'm
Yes.
If I'm going over time, please do,
Yeah.
because I have no sense. I think in terms of the relationship between mental health and marginality, I mean, I think it's important, as Deepa also just spoke about, that, you know, marginalization is about power and the operation of this in social, spatial, political, cultural spheres. And it's also linked to who holds control over knowledge as well. You know, some of the theorizations around the relationship between health and marginality obviously will suggest, which will not be news to us, is that you know, people in a marginalized position, that position can shape poor health and vice versa. I think one of the key things in terms of thinking particularly about caste discrimination and psychological distress, and I think I'll also say that this is sort of a new area for me, and it's something I've just started getting involved in the last few years. So I don't at all feel qualified to talk in an extensive way about the impact of caste discrimination on psychological distress. And this is work I've been doing with Dr. G.C. Pal, Nanda Kanuri, Sushrit Jadhav, and others around this area. And one of our, I think one of the key things from my perspective is very much about how we conceptualize mental health. And we need to, you know, avoid an approach that where terminologies, categories can be misused to pathologize particular groups. And we need an approach that looks at this at different levels: individual, family, community, institutional, structural levels. And also, you know, as Rochelle also just highlighted in the keynote, I mean, the global mental health movement doesn't really have it adopts an approach to think about mental health that tends to medicalize distress and doesn't really necessarily provide scope to think about well-being, as well as culturally and contextually specific vectors that might shape psychological distress and well-being. And I think one of the approaches we've taken, myself and colleagues been leading on this work, is to think about the notion of identity and how it shifts in identity, and how cultural and contextual identities shape marginalization and shape well-being. For example, we did a small project a few years ago thinking about how shifts in amongst low caste groups in religious identity and to religious conversion to Buddhism might impact on stigma, and how different forms of stigma intersect. Stigma from caste identity, stigma from linked to mental health might intersect. And I think one of the interesting things we found in this very small scale study with colleagues at Bapu Trust was that that political identity, the identity of converting to Buddhism and develop it, and that led to a political identity. Carving out that political identity was important in contesting stigma, but was also the conversion to Buddhism suggested that well-being was gained through the development of a dignity that came from a more articulate political identity, from contesting existing ideas of that were in place. So there was something about the politicalization of this that was important in terms of shaping well-being. And I think that's an important point more broadly in thinking about marginalization and health. Is there is a need for an approach that might look specifically at mental health in a more individual and community sense, but I think there's also a need to think about this at a very political level in terms of political organization and how people resist marginalization and discrimination, and think about other ways of being and living a good life. And I think that's very important in terms of how we also conceptualize this link between marginality and mental health. And I guess is a question of core to that is, what do we mean by mental health? And I think that's crucial in terms of thinking about this and in terms of what we do, because we have to be very careful in using the language of mental health in terms of thinking about marginalization. And maybe there are other ways of thinking, other concepts, other words, other ways of talking about this that might achieve the same goal. So that's sort of broadly what I wanted to say. And just to add one more point, I think there's something also about interdisciplinarity within this frame of different. We have, there's so many people working on caste issues within academia, and then there's many of us working on health and well-being issues. And how do we come together to think about these things in a joined up way and build on the existing knowledge base around caste discrimination that's out there, and more broadly on marginality. So I think I'll stop there, and we can pick up these issues in the next round.
Thank you, Sumit. I think in a very short time, you have managed to touch the emerging issues that are, the emerging new areas of work which are helping us to, in a way, unpack mental health and marginalization. where you talked about politicizing of identities in order to kind of gain more power, the relooking of or the reconceptualization of mental health, or questioning the way we conceptualize mental health, and a few other questions regarding interdisciplinary work in order to probably have a new language which looks at mental health and helps to define it from the perspective of different groups and not only the way it was done earlier. KP, we will move on to you. Drawing on your work in the mental health sector, could you talk about the discourse on mental health and marginality and how that has changed or transformed specifically in the context of gender and sexualities? What are some of the key shifts which have happened in the context of academic research, policy or programmatic interventions, and civil society engagement over the last 2 decades? So you have also about 4 minutes. tall.
Yes. Is the audio okay? Volume is
Yes, you're very audible.
all right. Okay, great. So there are actually sort of 2 parts to this question. So one is whether in our thinking on gender, sexuality and mental health, whether we have shifted, and if we have, then what have been these shifts? So I'm just going to first talk about, for the longest time when we've talked about gender and mental health, we have actually meant women and mental health. And that too, very often there has been, this coming together of reproductive health and mental health. Some ways sort of signaling a biological determinism of some of women's biology, hormones and reproductive functions, putting at risk for certain kinds of mental disorders. So that's been sort of, the story from where gender and mental health begins. Needless to say, then this woman that we have been talking about has always and only been the cis woman. In that sense, when we've talked about gender and mental health, we've talked about cis women and mental health, which means we haven't talked about men and mental health, nor have we talked about men's reproductive health and mental health, even in the binary cisgender sort of context. But then when we talk about sexuality and mental health, traditionally we have talked about men and mental health. Talked about sexual dysfunction in men, there we haven't talked about sexuality in women. So, in that sense, traditionally you've had, women have had reproduction and men have had sexuality when it comes to their mental health issues, right? And now this is the traditional cisgender binary notion that we have been looking at, and this is not specific to India. There's been a lot of sort of feminist psychologists who've written about these trends globally. In India, we have a very interesting writing by Professor Vindhya, who's done a 2-decade review on gender and mental health, psychological research on that, and that's an interesting thing to look at. Though, of course, like I said, primarily talks about cisgender people and heterosexual. So now have things shifted, and they have. And they have in a big way. And I think there was something in the question about policy program. And so I just want to say that in India, in the specific context of India and gender sexuality, I think we've had a struggle of more than decades, both in the streets and in the courts, to decriminalize homosexuality, which happened in 2018, the Apex Court decriminalizing homosexuality. And the same court in 2014, for the first time, said that transgender people have equal citizenship rights. And then in 2019, we've had the Indian Parliament that has passed a law on protection of the rights of transgender persons. So all of this together has had a major impact on how we've been talking about gender, sexuality, and mental health. So which means basically the old pathological transgender person and the old pathological homosexual person have in some ways entered conversation now in a non-pathological way. And that has taken us to, I must point out that as late as 2020, that we've had a bunch of, all the major mental health professional organizations in the country that first time came out and made a statement against conversion treatments meant to cure homosexual adults and transgender persons. So in that sense, there has been that shift in a big way. There is, of course, in addition, and the other thing that's happened again in the law policy context is that conversion treatments now through court orders are being banned. Does that mean that they have stopped? We don't know, or have they gone under the carpet? So those are all questions that remain. We've had court-ordered curriculum changes. So I'm saying court-ordered because I want to underline the fact that it doesn't mean that automatically side disciplines have become self-reflexive and have started thinking about the gender sexual other, but it's actually through courts and campaigns and advocacy campaigns that We've had in India a court-ordered review of curricula, particularly of psychiatry and forensic medicine, to a more affirmative sort of LGBT inclusion. So that's, in some ways, I would say that if I were to think about mental health today and gender sexuality, I would say that we've shifted from a pathologization narrative and a sort of denial of, this doesn't happen in our culture type of narrative, towards some level of tolerance in a sort of mainstream curriculum practice, mental health practice sort of a scene, some degree of acceptance, certainly visibility. So definitely, I actually have looked at about in the last few years, there have been at least 4 or 3 review articles which have been looking at like a 1-decade review of LGBT mental health in the Indian context, or non-normative gender sexuality and mental health. So visibility is there. Now, whether that visibility from pathologization, is this visibility about rights, about affirmation, or there is also, one can see, we've had in India again, when it comes to specifically queer and trans people, we've had a long history in health on HIV and a direct connection of risk groups and HIV for men who have sex with men, gay men, bisexual men, trans women, and so on. So in that case, there has been medicalization of some of these non-normative genders and sexualities. So in mental health, now we have more literature coming up on depression, suicide, substance use among queer and trans communities. So are we moving from pathologization to affirmation sort of articulation, or are we moving towards a new set of old risk groups, but for new set of problems? So from HIV now to mental health problems, all that remains to be seen in some ways. And I think, just as I close this, I think what is important is really on gender sexuality, which is not normative. So LGBTQ or queer trans mental health, I think what is significant is there is research happening, there is visibility now, but who's doing this research and what is their location? Is this who's setting the agenda? Is this a clinical orientation? Is it a welfare orientation? And so on, is really going to determine in many ways, whether we are just going to be swinging between pathologization and medicalization, or is there something else that's going to be possible? The kind of articulations that we heard earlier from Deepa and Sumit, who are basically sort of alerting us to the fact that, I think Deepa said it beautifully when she said that one of the things that structural discrimination does is it impacts the psyche of the one who's left out. It impacts the psyche to a point where you cannot come to the table and negotiate or articulate who you are and what you need. So I think those are things that remain to be seen as we move forward.
Thank you. Thank you. I have a very disciplined group of panelists. My job is easier, gives us also equal amount of time to speak. KP, I think that was very well put in terms of the way you managed to get across the shifts or the transformations that have happened in the last 2 decades. Is almost like unfolding of the movement with regard to mental health and marginalization that has taken place in India, with by looking at the domains of sexual and reproductive health, HIV, AIDS, and various other pathologizing as well as perspectives which were far more medical, shifting, at least in terms of our understandings. On the ground, what will happen in the future is, I think, something that we can all grapple with, but the shifts are definitely, they've come in. Now, moving from India to Nigeria, Hawa, how do you say your name?
Hawa, yeah.
Hawa. Okay, Hawa. So Hawa, my question to you is that your journey as a person with lived experience, as I said even when I introduced you, has been nothing short of actually inspiring. Could you talk about how this has shaped your ideas and vision for mental health, specifically for addressing the needs of diverse communities in Africa, where much of your work is located? And if also you could look in your experience at social identities such as gender and race, and how they shape mental health advocacy, research, and lived experience. Again, quite a big question with 2 key parts to it, but you can take about 4 to 5 minutes to speak about it. Yes, Hoa. Can you hear me? Hello? Hoa, can you hear
Yes,
me?
I can hear you now.
Yeah. Oh, so
Yeah.
shall I repeat?
Oh, no, I heard you fine.
Okay, so if you could please answer.
Thank you so much, Surinder. And I think first off, it's just so amazing to be on the same panel. I've heard so many amazing things from all of you. And, for me, it's like, what do I add to this? Because it's been so exhaustive, right? Okay, so as a person with lived experience, I think firsthand, one of the things that I saw is just how fragmented the system is. Coming from a place where, and I think this happens in many developing countries, where really you don't hear so much about mental health until there is a crisis, until someone close to you goes through something. And so that's when you begin to pull into say, okay, where do we go? What do we say? Who do we talk to? And because we've had years and years, decades of conditioning around mental health, and I always say it's what we laughed about in comedies, what we saw as headlines in the media, it's what was portrayed in the movies, all of those things. It's hard for you to begin to identify as anybody that falls within that category because it is, nobody wants to be that stereotypical image of who, that person is. And so one of the first things that I saw was a fragmented system, a system where, where is mental health within the healthcare system? Where is it really? Do I have to go outside of it? Or do I reach, is it a low-hanging fruit for just about anybody that knows where to get any sort of health solution? Do I just go to the normal places or the usual places rather? And so that was the first thing that I saw and, really influenced my idea and vision about mental health. How can we consolidate the system in such a way that it doesn't feel like, oh, it's those people and then it's we people over here? Because that is perpetuating an ongoing stigma that needs to, we need to pick apart. I think the second thing is about the quality of care. When it's easy to talk about the quality of care from the outside, but when you get in as a person with a mental health condition or a psychosocial disability, you see really what we talk about when we mean dignity and liberty, and every single person having that access to dignity and liberty when they approach or interact with the mental health care system. We continue to see issues of shackling, detainment, issues of forced treatment, coercion within these systems. And so for me, when I look at the work that we do, especially as a rights woman organization, it is how can we tackle these things? How can we first reorient that I am a full person with rights and I have a voice at the table and I should get the same quality that other people get as well. So I think it's those are the kind of things that I see that really inform how I look at, mental health as a person with lived experience. But when we talk about social identities, I will talk a bit more about race, but maybe gender as well. As a woman, I think KP has done a fantastic job really bringing out, the marginal communities within this space that tend to be left out of the conversation. But I would say women in particular are disproportionately affected by certain social issues. So whether we talk about sexual violence, women and girls, by the way, FGM, you're talking about, sexual and reproductive health and rights. We're talking about, religious and cultural oppression, where culture and religion have been used as tools to suppress and oppress and keep women behind in terms of fulfilling their potential in society. We're also looking at the lack of barriers to political participation. We're looking at, child marriages. We're also looking at financial exclusion. When you look at the layers of exclusion that really happen in terms of women, we begin to ask ourselves when we're creating solutions, how can we peel these layers back? How can we put them back layer by layer? Because what tends to happen is that maybe a lot of people who deal with or have to face child marriages and FGM are a different cluster from the people who generally might face, barriers in political participation. So it can be very nuanced in how we are trying to approach issues like this. But generally, and I think this is where it ties into race as perhaps a Black people or Africans, is really about our structural realities. our social-political histories and factors that really affect us as a continent in Africa. We're looking at issues with regards to, and I think it was mentioned earlier in the keynote, it's really about the diversity within communities as well. We're such a diverse group of people. So for example, in Nigeria, you have a country of over 200 million people, but we have languages of over 100 languages. And you're wondering, how do you begin to cater to different groups? Do you start with the majority, or do you go to the minority? Do you start with the furthest behind first? Or, where do you reach people? Do you use the internet and technology? How do we begin to ask ourselves questions about, access to internet being a basic, fundamental human right as well? And when people do not have access to water, or clean water in different communities, or people have to walk long distances to get these and all. So I think it's so nuanced that, when we really think about it, we're having to problem solve, and not just problem solve in terms of this is what the problem is, but from where we are. Where are we and where can we make the impact? Are we technologically savvy? How can we reach people with technology where we are at right now? When you talk about housing, unemployment, poverty, all of those things are really interesting in the entire mix. I'm sorry.
We'll come back to the strategies and opportunities, but I think you have laid out very beautifully how from the role of media, the role that media plays in shaping, even the kind of discrimination that takes place, to the response of the system, health system and the mental health system to people facing mental health issues, the layers of exclusion that happen. And of course, as you rightly said, which we too in India realize, the diversity of the population. We're not a homogeneous group, so people are not the same. And how do we understand the systemic impact that takes place, or the structural impact that takes place in all these different people? Thank you. I'm going to, with a little note of excuse or apology to the organizers, I'm going to club round 2 and 3 because I don't think we will have time to go through 2 more rounds. I will take questions from both round 2 and 3 because they both address potential strategies and opportunities. So you could focus on that, panelists, you could focus on that component which you feel is the most important. So Sumit, you are the first this time round. What kind of research do you think we need to invest in order to better understand linkages between mental health, marginality and development, especially in low and middle income countries? In the context of societies like what we have been talking, which are culturally complex, diverse, and hierarchical, and how do we transform knowledge production and discourse from pathologizing and racializing oppressed communities to addressing the structural issues that we spoke about in round 1, which lead to distress? And if you can also try and bring in an answer to that your work has essentially focused on ethnographic accounts of programmatic interventions for mental health in India, such as the district mental health plan. What kind of changes, according to you, need to be facilitated at a policy and programmatic level in order to address mental health as a development and governance issue? So we're looking at strategies, we're looking at policy initiatives, the way forward.
Great, thanks very much. It's the questions that were sent to us are really a great set of questions. So it's really got me thinking a lot. In terms of the point about where we need to invest in terms of the linkages between mental health, marginality, and development, I think three or four words came to mind. I mean, from my perspective, but the main thing was this: how do we privilege the voices of marginalized groups, both in the research, but also in determining what sort of research might be done and should be prioritized. And I think that's, to me, that seems to be central to this in terms of sort of how we go about research. The second thought that came to mind was, what is evidence, and what constitutes evidence? And I think it's a really important area in the field of global mental health to think about. Well, particularly when there's these discourses around that are very positivist and focused on particular forms of evidence. So And to that mind, I think thinking about research that's qualitative, ethnographic, participatory, interdisciplinary, but also research that brings in sort of different forms of methods. And that's challenging to do in the context of research funding for academics and, project time. We've faced in work we did in recovery in Uttarakhand, we faced this problem of having a 6-month project, but then trying to do something participatory, and it doesn't fit with people's time. And so how do you do that in a way that's safe, in a way that's kind, in a way that's truly sort of participatory? It's very difficult to do. The other thing that comes to mind is also there's a need in terms of this point about evidence for more reviews of what's out there. So including unpublished evidence, including, on stuff that's not even written down, but also things like meta-syntheses of existing ethnographic work, of which there's a vast amount. And in terms of transforming knowledge production from pathologizing and racializing to structural issues, I think my answer is largely the same, but I think a key factor here is around the power dynamics that shape who's involved in conceptualizing the types of questions we're asking, and so how can people from marginalized backgrounds, or people from communities, non-researchers, so to speak, be involved in deciding and thinking, helping us to think through what questions are important. And obviously that's part of that is about how we shape and do our research in terms of, the process of how we come up with questions, and having space to actually consult with people and do that in a way that also gives value to their time and their knowledge and their wisdom. And I think one of the challenges we found in some of our participatory work in North India was that how do you recompense people in a correct way, and how do you take account of the fact that people's lives are very complex and very difficult, and how do you do that and build that into projects? And that's something, one of the lessons we've learned is you need to build that into project time, and do it in the right way. In terms of the final point, and just to conclude on the point about the DMHP, if I might, and the question was really about what kind of changes need to be done at a policy and programmatic level to address mental health as a development issue. I guess a lot of my work on the DMHP has been ethnographic. I think it's important to say that there's a lot of good people working within DMHPs across all the states, working in very difficult circumstances. And some of the problems and challenges with the DMHP relate to broader issues within how the state delivers services. And I think we've recently done some work looking at how community mental health NGOs in India innovate in delivering socially inclusive care. And I think that work seems to suggest that intersectoral integration is important in how some of these NGOs deliver more socially inclusive mental health care. So linking with development, linking with gender, linking with social justice organizations and departments, it might be a good way forward for the DMHP, which I know is done, but doing that, thinking about that, and also closer linkages with local NGOs and local communities is an important aspect. And finally, I think defining mental health in broader social and structural terms, in which there's been, a major shift in some ways in how that's being done. But I think that needs to be pushed, and maybe the fundamental problem is DMHP is within health; it's within the health department, and that. So, can we reconceptualize where mental health as a state priority sits in a structural way within the state? So I think I'll just stop there, Surinder, because I know we're on a bit of a time trajectory.
Thank you. I think we have some excellent suggestions from you in terms of possible challenges and strategies to address both at the methodological, kind of frame which we need to adopt, giving more space to the voices which today are powerless. And of course, as you said, inclusive care and intersectoral, linkages, which we speak about, and which I think it's time that we started to work towards. KP, I will come to you, and I'm going to club both questions again. Okay, Sumit did an excellent combination of both, so you have a tough act to follow. So to build on his intervention, is there a need for more research on how structural discrimination leads to mental distress or suicides amongst the LGBTQI populations? And what kind of data or research exists on this currently? For example, we know that population data on trans or gender non-binary persons is inaccurate. What kind of parameters, according to you, do we need to assess or evaluate this? And I'm going to club the next question with it, which is in terms of looking ahead. Your work is also focused on constructive critiques of the PSY disciplines in India. Can you identify some key transformations which are required in these disciplines, both academic and practice, in order to address mental health as an intersectoral development and social justice issue? In a way, it is, there is a similarity with what Sumit said. If you can focus on those components which you think are unique to your community.
Okay, thank you. It's actually an easy act to follow because I'm just going to reiterate some of the things that were already said by Sumit, but maybe a few more examples of, since I have a little more time now that he's sort of laid the ground. So I'll start with one is this, the reference to the population data, I think in 2011, the government of India did in their census for the first time included this category called male, female and other. And that was, of course, a huge disaster for many reasons. One is, of course, we got severely underrepresentation. So, we got something like 4.9 lakh people who were identified as other. And we know that the trans population of people who don't fit into the box of man and woman are much more. And there are many reasons for this. One is, of course, that in our region, I mean, not in India, South Asia, actually many parts of the world, there are several socio-culturally, regionally determined identities that fall outside the male-female gender binary, right? So what were they actually trying to do? So when you have something like a national census, what are these enumerators actually measuring? It's a question that, I mean, are they basically looking at hijras who are part of Gharanas and saying that, okay, these are all people who are male, female, other. So we don't know who this other is, So anybody who's socially recognized as Kinder, Hijra, then becomes other. Then someone like me, a lot of people would be still read as male and female, right? So I think the question here is that if we want to really understand, and I have actually had these conversations with many bureaucrats and planners who always want to know with respect to any community, when they want to think about, how do we do interventions, they want to know how many of you are there. Right. And I think that question itself is a problematic one when it comes to communities that have been, that have faced a lot of discrimination, violence, stigma, continue to remain hidden. So it's very unlikely that this methodology of door-to-door method, it's unlikely that you'll have young people in that family coming out and saying that, mark me as other, right? Yeah. So obviously it means we'll have to think of, if we are thinking of population estimates, we'll have to do this very differently. And one of the ways in which people have tried it again in the HIV context is in the context of service use of certain kinds of services. So services, for example, which is again it's a very specific community then that you're catering to. But I think what I'm going to say here vis-a-vis what kinds of research we need to be doing is going back to what Sumit was saying. One is that, why are we gathering this data? Then, that will, and who is setting the research priorities? I think the question about who speaks and what is evidence really is at the core of all of this. So, so one is representation. So I'm just going to say here again 2 examples. One is, I remember in 2011, there was an NGO that was working on violence against women, cis women in marriages. Went ahead and did a study on violence faced by violence in intimate relationships of lesbian couples, right? This is 2011. And we wondered who wanted to do this research. 2011, homosexuality was still a crime in India. There was the violence that lesbian women were facing was primarily from their natal families, including forced marriages. And here you had a NGO that was working on violence against women and was wanting to study intimate partner violence between 2 lesbian women, right? So who sets these agendas? What is the community's participation? Are these important research questions for the community? And more recently, there is somebody who wrote to me saying that they want to study menstrual health among trans masculine folks. And again, I mean, where are these questions coming from? Who was asking these questions? Why? So it goes back again, I mean, in research methodology itself. For a long time, many of these communities that we're talking about today, whether it is people living with mental illness, whether it is people marginalized because of their caste location, whether it is people marginalized due to gender sexuality, we have been in that sense the museumized other, who has always been studied by somebody who's in a location of power. And so if we continue to have research of this nature, where somebody in location of power decides what is curiosity for me, because these are voyeuristic questions. Violence happens in lesbian women's relationships. How are trans men managing? I think it's an important health question, but if it's an important health question, for transmasculine folks, how do they want to ask this question? How do they want to measure this? Those are all, I think, very, very important things to think about. So going back to this population-based data, I think, why are we doing this study? I mean, like for me, when I think about structural determinants, I would say that if we were doing something like a mapping study, it would be important to do, like, the methodology for a mapping study on levels of education and employment among trans people in India or in a state of India would be thought of in a particular way. And similarly, let's say prevalence of suicide or non-suicidal self-injury among LGBT young people, right? So how are we, first is, what is the research priority? Where is this question coming from? Is the community involved? Community involved in decision-making about whether this is a research priority. So I think those are all things that will decide how we should do, research. And I just want to give a couple of examples. I mean, I do know right now there's a study of transmasculine health, which is an online study. It has all trans men steering group from the community that is taking very important decisions about tools and sampling and all of those things. And I think that when we are thinking about, I think Sumit raised this question about also resources and funding. I think if we are able to think about how do we ensure community participation and community empowerment. So maybe my research includes something on talking to communities about how research gets done and some sort of capacity building around that, and then working with communities towards deciding, what kind of research needs to happen. I think it's interesting. Again, just to conclude, some work from public health, from actually HIV researchers on syndemics. Interesting when it comes to LGBTQ persons. They're already looking at things like violence, substance use, and HIV risk. And connecting that to depression, or connecting that, so links between class, occupation, violence, discrimination, and connecting that to health outcomes. So some of that are interesting. Those are interesting frames, I think, that we can look at. I think I'll stop here on the second question about what needs to happen in disciplines is largely this, about what kind of knowledge is being produced, which is informing our practice.
You have answered that, yeah. Thank you. That was actually very, for me, very, very interesting. We are moving now into the kind of work that is required in the future. And I think this conversation needs to be taken further by all of you beyond this panel, so that we can work further on this, because it should not remain only at a discussion point. Thank you, KP. I will go on to Hawa. I'm going to club both questions, so you will have to be again a little alert. We're running a little short of time. I have requested for an extra 5 minutes to do justice to the two panelists who need to speak. So Hawa, you have been leading a mental health initiative, She Writes Woman, which empowers people with lived experience to tell their own stories, co-create their solutions, and advocate for their own rights. Can you share some of your insights in very brief on the kinds of intersectional solutions your organization advocates for persons with lived experiences across different marginal communities, specifically in Nigeria and Africa? In a way, it's taking further what KP was just talking about, but shifting continents from Asia to Africa. And the second question, which I'm going to club with it because we will not have time later, is what are the opportunities that you envisage for cross-cultural collaborations amongst low and middle income countries for advancing mental health for all? And what kind of solidarities and alliances can we create among communities in these contexts? And finally, how can we promote leadership among young people in such collaborations? So the second part is about networking, collaborations, and alliances. The first is about, sharing your insights on the kinds of intersectional solutions. Yeah.
Thank you so much, Surinder. I'm going to try as much as possible to really keep it short. It's okay. Our work at She Writes Woman in Nigeria really has been on twofold. On the one hand is what we call Safe Place Nigeria. How can we ensure that when it comes to mental health, we're not just having conversations in echoes where it only affects people that have mental illness in that sort of regard, where it feels like, oh, I'm not part of those people, so that must be it. Because what we're really doing is that when we use that approach, we're leaving out a large number of people, actually the majority of people, in the conversation around mental health and wellness. And so for us, one of the things that was so imperative was, how do we reach people where they are? Nigeria has a far better statistic with regards to mobile phone penetrations to internet penetration. And so instead of looking for more ways to digitize things in terms of the using the internet, all of those things that I feel like leave a lot of people who are in dire need behind, we're looking at how can we put it within a mobile phone sort of setting. So that's when we came up with our 24/7 toll-free helpline that pretty much puts the power in everybody's hand. And because stigma is such an important part of it, and people really are not at the point where, mental health is completely normalized just yet. There's been a lot of progress over the years, but we're just not there yet. People feel more comfortable talking to a stranger actually than they are talking to people within their communities, because there's that sense of association in terms of your identity. And so it is, I want to feel safe in my community, but I also want to get help. And if I talk about this within my community, then perhaps I might endanger myself or reduce social benefits of that identity within that community. And so I would seek it somewhere else. And so the mobile phone is a very easy way out for them. 24/7. But one thing that is very important for us to mention is the fact that, for us as an organization, we find that about, 7 in 10 women that actually make contact with us are women who have experienced sexual violence or in situations that have to do with sexual assault and things like that. And so you see that intersection where it's hard for us to talk about mental health, especially with women, without actually addressing the sexual violence issue. It's something that we have not been able to, really, alienate of some sort. But going beyond that, we have a free and unlimited teletherapy as well, because we're very aware that although the helpline is somewhat of a first response, it kind of stopped there. And we're looking at a country and even a continent, a very similar statistic where you have about one psychiatrist, for example, to millions, of Nigerians and things like that. So it's like for Nigeria, it's about 1 million to 1.3, thereabout, one psychiatrist over 1.3 million people. So it's ridiculous how much burden is on the mental health system and how we need to democratize that system as well. So we have free and unlimited teletherapy. We're working with government to scale all of these, but it's also working with regards to reform. How can we embed some of these social solutions in existing infrastructures that are already within communities? So I think that's how can we piggyback of certain solutions that are already embedded in certain communities. But as far as alliances go, I think across the continent and even in other parts of the world, even in India, we find very good alliances with regards to social justice, social solutions in particular, because we have very similar socioeconomic structures and even similar political structures as well. So it's easier to navigate some of those things, population issues, diversity issues, issues and opportunities really, because they're not just issues, they're opportunities for innovation within those settings as well. But leadership amongst young people would be about really leaning in to different variety of knowledge around mental health. We're coming from, settings of biomedical approaches to psychosocial approaches. But even beyond that, there's a psychosocial, spiritual, religious, settings as well that we cannot really, remove, because these are who people are. These are their identities. And so we must begin to look at those perspectives as well when we build leadership within the mental health space. We must ensure that we allow young people to realize that mental health is not just a medical issue, it's not just a public health issue, it's also a social issue, that everybody has a role to play at the table. And so for us, really, it's about flying the banner of nothing about us without us. I'm a person with a lived experience. I must be at the table when issues are being discussed about me, issues that are going to affect me, not just in mental health, but even in other settings that I have to do or play a role in affecting my own experience of life in a particular place as a person with a mental health condition.
Thank you. That was fantastic. If I had an award, I would give it to you right now. To put a very, very complex issue, right at the center and answered both set of questions beautifully. Thank you. Thank you, Hoa. Deepa, we started with you. We're going to end with you today. So to build on what Hoa said, can you talk about some strategies which have worked in your work to address the mental health needs of the community you work with, specifically the NT-BNT, and What are, according to you, some of the learnings or challenges for addressing mental health as a development and social justice issue? Because that's been, your key focus. And the kind of systemic changes, according to you, which are needed to be facilitated to improve the mental health and well-being of marginalized communities. And if you can suggest 2 to 3 ideas which you believe can be implemented at a larger scale, not only with specific techniques.
Yes.
Yes, please.
सिस्टमेटिकल चेंजेस के बारे में जब मैं सोचती हूँ तो मुझे एक सवाल मन में आता है कि क्या भारत के पास सिस्टम नहीं है, भारत के पास व्यवस्था नहीं है, अंतरराष्ट्रीय लेवल पे व्यवस्था नहीं है। तो अगर भारत के कॉन्टेक्स्ट में बात की जाए तो हमारे पास बहुत ही ताकतवर कॉन्स्टिट्यूशन है। अड़चन वहां पे ये है कि वो इन प्रोसेस नहीं है। जो प्रक्रिया में लाने वाले लोग हैं, उसको इन प्रोसेस करने वाले लोग हैं, वो बहुत ज्यादा उस तरह के पावर वॉक के दिमक के साथ घिरे हुए हैं जो लोगों के पास सही मायने में मेंटल डिग्निटी, मेंटल एम्पावरमेंट, उनके कई मायने में जो उनके पार्टिसिपेशन हो, उनके लीडरशिप के जो मौके हो, उस एस्पेक्ट से वो नहीं जाते हैं। हमारी काम की जगह हो, शिक्षा की जगह हो, सहभाग पार्टिसिपेशन की या नेतृत्व की जगह हो, हम कितना गारंटी से कह सकते हैं कि जो कम्युनिटीज या जो लोग मार्जिनलाइजेशन का एक्सपीरियंस करते हुए आते हैं, वो उन्हें खुले तौर पर स्वीकार करते हैं, उनके बीच में कमजोर होने की भावनाएं नहीं इंजेक्ट करते हैं या उनको नाकारते नहीं है, उन्हें फुल फोर्स डेमोक्रेटिक ताकत के साथ पार्टिसिपेट करने के लिए वो वातावरण देते हैं। तो शायद इसका जो जवाब है वो बहुत हद तक ना में आएगा। तो मुझे एक चैलेंज लगता है कि हमारा कॉन्स्टिट्यूशनल अप्रोच जो है वो इन प्रोसेस करने के अंदर जो दिमाग है वो अपनी ताकत नहीं लगा रहे हैं, बल्कि बहुत बड़ी मात्रा में यहाँ पे मेंटल डिग्निटी को न मानने का, लोगों की मेंटल डिग्निटी हार्म करने का, मानसिक सम्मान न करने का कल्चर बिल्डिंग का भी एक प्रोसेस है। उस तरह की संस्कृति का सामान्यकरण जो है वो यहाँ पे किया जाता है। दूसरी में एक जो चैलेंजिंग बात है कि लेंस ऑफ इंटरसेक्शनलिटी, कि जो परतों के साथ हमें समूह को देखना है, व्यक्तियों को देखना है, वो कई बार बहुत ऊपरी तौर पे होता है। जैसे कोई 2 दिन से भूखा है, कोई आने वाले 2 महीने या पिछले 2 महीने तक भूख का सामना कर रहा है, और कोई हो सकता है कि आगे के 2 साल तक वो भूखे रहने की गुंजाइश है। तो उसके सवालों की जो इंटेंसिटी ऑफ डेप्थ है, वो बाय कम्युनिटी अलग है, वो बाय आइडेंटिटी, बाय सोशल लोकेशन काफी अलग है। हमारे साथियों ने कहा कि मेंटल हेल्थ जो है वो बस एक मेडिकल इशू नहीं है, वो एक सोशल इशू नहीं है। मैं उसके साथ जोड़ के कहूंगी कि मेंटल हेल्थ जो है वो पॉलिटिकल विषय भी है। उसको राजकीय परिप्रेक्ष्य में जब तक हम नहीं देखेंगे, पॉलिटिकल कमिटमेंट में, इथिकल रिस्पॉन्सिबिलिटी में हम नहीं देखेंगे, जो भी डिसीजन मेकर्स है उनकी कमिटमेंट वहां तक नजर नहीं आएगी, तो मेंटल हेल्थ का जो विषय है वो बहुत ही आसानी से कम ताकत के साथ जो है वो सामने आते हुए नजर आएगा। हिंसा को भी हम कई मायने में एक सीधे रेश में देखते हैं, लेकिन अगर हम आसपास देखेंगे तो मॉब लिंचिंग के प्रमाण है, एट्रोसिटीज के भारी भरकम प्रमाण है, मार्जिनलाइज कम्युनिटी से आते हुए औरतें, बच्चों, बुजुर्गों के साथ होते हुए जो है लैंगिक हिंसा के प्रमाण बहुत बड़े पैमाने पे है। ऐसे हालातों में जो पावरफुल सिस्टम है, पुलिस यंत्रणा है, पॉलिटिकल सिस्टम है, पॉलिसी धोरण बनाने वाली व्यवस्था है, क्या वो सुनने के लिए तैयार है? तो हमें फिर से उसका जवाब आएगा कि उनकी वो सेंसिटिविटी जो है वो कुछ समूह के लिए बहुत ही ज्यादा असंवेदनशील नजर आती है। कुछ समूहों को वो गृहीत धरते हैं, ग्रांटेड धरते हैं कि आपको कुछ चीजों की जरूरत नहीं है। तो ये मुझे बहुत ही ह्यूमन राइट का हनन लगता है, लोगों के मानवीय अधिकारों का हनन, जो मानसिक नजरिए से होता है, जो भावनिक नजरिए से होता है, उसके कोई भी एविडेंस नहीं पेश आते हैं। वो एविडेंस बेस हम पेश नहीं कर सकते। वो व्यवहार है, वो वर्तन है, वो बर्ताव है, वो लोगों को नकारना है, वो ऐसी तरह से है जो लिखित स्वरूप में हम नहीं पेश कर सकते हैं। वो एक छद्मवेशी तरीके से, बहुत ही मैं कहूंगी कि संरचना और ढांचे का आधार लेते हुए सिस्टम का एक सिस्टमेटिकल, फिर वो सिस्टम मनुवाद की है, ब्राह्मणिकल पेट्रियार्की की है, रिग्रेसिव मैस्कुलिनिटी की है, वर्चस्ववाद की, वर्गवाद की है, और वो हर समूह के ऊपर बाय इंटरसेक्शनलिटी अलग अलग पॉइजनिंग इंजेक्शंस दो है वो वहां पे देती है। मुझे कुछ चीजें मेरे काम से बहुत ज्यादा जरूरत लगती है कि कई जो केतकी ने भी मुद्दा उठाया उसके साथ आगे जोड़कर मैं कहूंगी कि मार्जिनलाइज कम्युनिटी से आने वाले लोग बस रिकमेंड ना करें, मुझे लगता है वो कम्युनिटी लेड रिसर्च करें। उनके अपने सवाल है तो वो अपनी प्रक्रियाओं में आए, और एज अनुभूति हम कोशिश करते हैं कि जिनको शोषण के केंद्र पता है, जिनको वायलेंस के सेंटर्स पता है, जिनको दहशत के सेंटर्स पता है, वो खुद आगे आए और अपने सवालों को लेकर वो अपनी काबिलियत के साथ, अपने अनुभवों के साथ खुद के कम्युनिटी लेड रिसर्च करे, जो एक प्रैक्टिसेस हम अमल में लाते हैं। दूसरा, मुझे एक हमेशा लगता है कि कई बार जब हम इंक्लूसिवनेस की भी बात करते हैं या मेंटल डिग्निटी की बात करते हैं, वहां पे हम बस रिप्रेजेंटेशन की बात करके छोड़ देते हैं। हर जगह पे नहीं भी होता होगा, लेकिन मैक्सिमम रिप्रेजेंटेशन फ्रॉम मार्जिनलाइजेशन की बात हमें करनी चाहिए। एक दीपा पवार आने से, 2-3 उस समूह के लोग आने से वो ताकतें बढ़ पाएगी क्या? तो शायद उस तरह की ताकतें नहीं भी बढ़ पाएगी। लेकिन जितना पॉसिबल है, जिनके मैं हमेशा मुझे लगता है कि एक्सपीरियंस सुनना, एक्सपीरियंस को सपोर्ट करना और खुद को एक्सपीरियंस होना, इसके अंदर बहुत ज्यादा रेंज का फर्क है। कि मैं किसी का अनुभव सुन रही हूँ, मैं किसी के अनुभव को, ज्वलंत अनुभव को सपोर्ट कर रही हूँ, और मुझे खुद को अनुभव है, इसके चश्मे का लेंस ही बदल जाता है। तो क्यों ना जिनके सवाल है वो अपने लेंस से सॉल्यूशन को देखे, और फिर वो मेंटल डिग्निटी के ऊपर होते अतिक्रमण हो, मानसिक सम्मान की चिंताजनक स्थितियां हो, और मेंटल हेल्थ केयर एक्ट एक्सेसिबिलिटी के जो बिल्कुल भी चिन्ह नहीं दिखाई देते हैं, उसके बारे में उभरती हुई चर्चा है, मुझे लगता है वहां पे देखना बहुत जरूरी है। उससे पॉजिटिव नैरेटिव्स बिल्ड होंगे, लोगों के कम्युनिटी के भीतर के पॉजिटिव नजरिए जो बिल्ड होंगे। एक दो चीजें मैं ऐड करूंगी कि मुझे बहुत लगता है कि इंडियन कॉन्स्टिट्यूशन, हम अगर बस दस्तावेज ना समझे, और अगर बस हम डॉक्यूमेंट ना समझे, और बस हमारे अधिकारों की किताब ना समझे, तो वो मानसिक आरोग्य के बारे में एक मूवमेंट बिल्डिंग का एक दिशा निर्देश कर सकती है। वो हर मायने में लोगों की प्रतिष्ठा के बारे में, कम्युनिटी के प्रेस्टीज के बारे में बात करती है, कम्युनिटी और व्यक्ति के डिग्निटी के बारे में बात करती है, सहभाग और नेतृत्व के बारे में बात करती है। और ऐसे सारे हालातों में बहुत ज्यादा जरूरत है, जो एक प्रैक्टिस हम करते हैं, कि लोग अगर अपनी संविधानिक गरिमा के लिए सचेत होंगे, वो अपने कॉन्स्टिट्यूशनल डिग्निटी और एक्सेसिबिलिटी के अगर सचेत होंगे, तो एक वर्चस्ववाद कम्युनिटी ने उनके भीतर जो न्यूनगंड का इंजेक्ट किया है, जो कमतरता की भावना है, क्रिमिनलाइजेशन के एटीट्यूड, आप ही जिम्मेदार हो, आप ही सॉल्व करोगे, आप ही आगे आओगे, ये जो जो बमबारिंग है कम्युनिटीज के ऊपर, लेकिन हम आपको रिसोर्सेस नहीं देंगे, हम आपको रास्ते नहीं देंगे, हम अपनी जगह नहीं छोड़ेंगे, आपको और ताकत से कम करेंगे। ऐसे हालातों में मुझे लगता है कि ह्यूमन राइट पर्सपेक्टिव और भारत के स्तर के ऊपर संविधानिक अप्रोच की बहुत ज्यादा जरूरत है। एक अंत में ये कहूंगी कि मैं जब मेंटल हेल्थ को देखती हूँ, मुझे लगता है कि वो बिल्कुल, जैसे हमारे और साथियों ने कहा, कि वो आरोग्य तक सीमित मुद्दा है ही नहीं। आरोग्य उसका एक महत्वपूर्ण अंग है, लेकिन वो न्याय का मुद्दा है, क्योंकि जो सदियों से हिस्टोरिकल डिस्क्रिमिनेशन चला आ रहा है, औरतों के ऊपर, जाति आधारित समूह के ऊपर, अल्पसंख्यक समूह के ऊपर, आप विस्थापित हो उससे उसका नजरिया हो, असंगठित कामगार हो उसके बारे में होने वाला नजरिया हो, तो मुझे बहुत बड़ी मात्रा में लगता है कि हम अगर मानसिक स्वास्थ्य को सामाजिक न्याय की परिभाषा में नहीं देखेंगे, तो मेंटल हेल्थ अपने आप में अधूरा जो है, मतलब वो बस मेंटल हेल्थ की दवाइयां या सर्विसेज डिलीवरिंग तक का मुद्दा नहीं है। मेंटल जस्टिस का वो मुद्दा है कि अगर आपका मेंटल हेल्थ में कोलैप्सेशन हो रहा है, आप मानसिक परेशानी से गुजर रहे हो, तो फाइंड आउट करो कि सोशल हायरार्की से आते हुए उसके रूट कॉज क्या है। आपको वो मिलेंगे सोशल हायरार्की के अंदर, वो पिरामिड के अंदर, जो जेंडर बायस्ड ट्रीटमेंट आपको देता है, जो जाति के नाम पर आपको अलग करता है, जो प्रांत के नाम पर, रंग के नाम पर, भेद के नाम पर कई सारे भेद और उत्पीड़न जो है वो तैयार करता है। अंत में मुझे बहुत ज्यादा ताकत यही देता है कि इंडियन कॉन्स्टिट्यूशन जो हमारा कहता है कि इस देश के अंदर धर्म हो, भाषा हो, जाति हो, प्रांत हो, रंग हो, लिंग हो, नस्ल हो, किसी भी आधार पर डिस्क्रिमिनेशन, एक्सप्लॉयटेशन, छल कपट हो नहीं सकता है। मेंटल हेल्थ के कॉन्टेक्स्ट में आने वाली बहुत ही मेडिकल टर्म में होने वाली, अगर हम कुछ स्टेटस छोड़े, तो बहुत बड़ी मात्रा में गैर बराबरी, एक्सप्लॉयटेशन, छल कपट के कारण लोग बहुत ज्यादा तकलीफ और पेन महसूस करते हैं। और मुझे लगता है कि ये नजरिया जो है वहां पे काम आएगा, और पेट्रियार्की को जड़ से नष्ट करना, ये अंतिम विजन मुझे लगता है मेंटल हेल्थ के सम्मान की तरफ जाने का या डिग्निटी की तरफ जाने का हो सकता है।
Thank you. Thank you, Deepa. I know it has been a tough 40-45 minutes trying to answer very complex issues and your lifetime work within a very, very short period of time. But I must say that I personally feel very privileged to have heard the four of you, Deepa, Sumit, KP, Hawa, sharing not just your experiences, but your work and your insights. And I think some of the key questions that you posed, that we need to look at mental health not only, and we say this, KP, in class, not only from the biomedical perspective, not only from the tertiary or the treatment perspective, but we need to look at it as a social issue. We need to look at it as a political issue. And what Deepa said at the end, as a constitutional right, and the Constitution has every component which we hope to address. If mental health is not addressed only from within the health system, from the biomedical perspective, but from the perspective of people's lives, who they are, what they are, and the multiple layers which they have to kind of traverse each point of time, we will begin to at least start addressing some of the distress and the inequities and the injustice that has been there for so long. And of course, KP and Sumit spoke about, as well as actually Deepa and Hua also spoke about the fact that we need to also therefore question, how do we frame research? What are the questions? What are the concepts that we use? Who defines them? Who does research, etc., etc. So it's not enough to only look at in terms of what kind of an issue it is, but we need to also look at frameworks which are not typical research frameworks and typical frames in the way we do research. I have a huge amount of scribbling here, which I'm going to try and make sense of, because we have 3 rounds of questions that we have answered, looking at the impact of structural determinants on mental health, well-being and development, and then to strategies, opportunities, and the way forward. And I think all people who have participated in this particular panel discussion have a lot of food for thought and a lot of work on their table, which I hope we will all work towards as we move further. Kaustubh, my sincere apologies. We have, I know, overstepped time, but I was very, very shy of stopping any one of them, because the discussion was very, very rich, and I think we've all benefited from it. Thank you once again, Deepa, Sumit, KP, and whoever. Thank you so much. And thank you, Kaustubh.
Thank you.
Thank you
Thank
so
you
much.
all. Thank you all. Thank you, Deepa, Sumit, Hawa, KP. Thanks. So for all, I think attendees, we will take 2 minutes break. I know we are running a little late, but we'll take 2 minutes break and we'll go back to the next session. My colleague Arjun will be facilitating next session. That's a webinar on suicide prevention. So we'll just take 2 minutes break and we'll be back. Thank you.
Thank you.
Okay, maybe we can begin, considering we're running a little short on time. A very good evening to all of you. My name is Arjun Kapoor, and I'm a research fellow at the Center for Mental Health Law and Policy, Indian Law Society, and I will be facilitating the third session for today's conference, which is titled Intersectoral Strategies for Suicide Prevention. Suicide, as we all know, is a complex and multidimensional phenomenon. We know that there are various factors and social determinants which actually contribute to suicides, and most of these factors are social, economic, and cultural in nature. The World Health Organization sort of recommends countries across the world to put in place suicide prevention strategies at a national and at a state level, which look at suicide prevention from an intersectoral point of view, which means really looking at solutions and strategies for suicide prevention which touch upon different areas of governance, whether that's education, rural development, employment, development of women and children, and other forms of intersectoral strategies. So in this session, we hope to touch upon some key intersectoral strategies to address suicide prevention, and also look at specific vulnerable communities who are specifically affected by risk factors which contribute to suicides. The format of this session is essentially going to be in the form of individual presentations. So we have 4 experts who have been working in the space of suicide prevention, who will be making a presentation for 10 minutes each. And then at the end of each of these presentations, we will have a question and answer session. So we invite the audience to put in their questions in the chat box, and we will post these to the speakers at the end of the session. So without further ado, I'd like to introduce the first speaker for today, who is actually not present in person. They have sent a pre-recorded video, which we will be shortly presenting. I'd like to first introduce Dr. Diane Machado, who is a PhD in epidemiology and population health. She's a research fellow at Harvard Medical School and a research associate at the Center for Data and Knowledge Integration for Health. Dr. Machado was also a PI of a recent study which mainly focused on evaluating social determinants and the impact and mechanisms that link a cash transfer government program to better mental health and lowering suicide risk, specifically in Brazil. Since 2007, Dr. Machado has been investigating suicide and mental health related outcomes, and also focusing on gender differences on those outcomes. Her research has contributed to the use of new strategies for evaluation of mental health and cash transfer programs, showing that data analysis can be powerful tools to evaluate the impact of policies and interventions for suicide prevention at a lower cost. Dr. Machado, because of the time difference, was not able to be present in person, but as mentioned, she has shared a pre-recorded video, which we will be broadcasting now. And Dr. Machado will be speaking on the topic of cash transfers as an evidence-based strategy for suicide prevention, particularly in low and middle income countries. So if I could request Vijay Lakshmi to put up the video and broadcast it. Thank you. Thank you.
Hi, everyone. Thank you for taking the time to watch my presentation today. I am Diane Machado. I'm a psychologist and epidemiologist affiliated to Cidades Fiocruz in Brazil and to Harvard Medical School. And today I will be presenting about the cash transfers, evidence-based strategy for suicide prevention in low and middle-income countries. Suicide is a very important public health problem. It makes over 700,000 victims around the world every year. And this is a multi-causal phenomenon, which means that there are many risk factors involved, and not all cases are associated with psychiatric problems. Studies have shown that 80 to 98% of the cases in high-income countries are thought to be affected by psychiatric disorders, while this proportion is much smaller in low-income settings, with 58% of the victims actually meeting the criteria for psychiatric diagnosis in these settings. Searching about the risk factors, 62% of all studies in low-income countries identify the association of suicide with general poverty measures. In Brazil, we have also been consistently finding association between economic factors and increased suicide risk. This study we published in 2015, we found that Brazilian municipalities with higher income inequality also had higher suicide rates, and municipalities with better economic situation, with high income, had lower suicide risk. The most affected people were the least educated, the First Nations populations with the indigenous populations that had over 100% higher rates than the general population, and the highest percentage of growth was found in the northeast of Brazil, which is the poorer region of the country. Later, we tried to investigate if the mental health services in Brazil would be able to prevent suicide in the country. And we found not a statistically significant association between the community health services coverage in the Brazilian municipalities with the suicide rates. We don't know if it's because the coverage is just not high enough to actually impact on the populational rates, or because these services are not prepared enough to deal with this specific population. So since we have been finding the socioeconomic factors seems to play an important role in the suicide risk in Brazil, and the community mental health services have not been able to prevent them, what would you be able to prevent? Would a cash transfer be able to prevent suicide? So we performed this study in 2018, and we found that Brazilian municipalities with higher coverage of the Brazilian cash transfer program had a 6% decrease in the rate of suicide. Another study investigating a cash transfer program was performed in Indonesia, and it also found a decrease in the suicide rates, a 10% decrease of suicide rates in the sub-districts where the program was implemented. So most studies have been showing a significant association between socioeconomic factors and suicide, but there is a limited evidence on the impact of socioeconomic interventions to reduce suicide. In our literature review, by the time, we only found these two studies that were performed at the ecological level, which means like by aggregate unit of analysis. So to address this gap, we used the 140 million cohort, which covers over 50% of the Brazilian population. And in this cohort, we identified those who received the Bolsa Família program, the Brazilian cash transfer program, and those who did not. And in these two groups, we identified who was a suicide victim and who was not. And we follow up all these people in this cohort, the 140 million, from 2004 and 2015. Then we published this paper recently that showed an association between the Bolsa Família receiving the Bolsa Família and lower suicide risk. We found that among the non-beneficiaries, the rate was 10 per 100,000 inhabitants, while among beneficiaries was almost half. So which means that people who did not receive the program had almost twice higher suicide rate compared to those who received the cash transfer. Running more statistical models, we consistently found a significant association between receiving the cash transfer and decreased suicide risk, reaching to 56% decrease in our final model. We also found that the female were the most impacted, had the highest impact with higher decrease in suicide risk, and people from 25 to 59, what we would expect as those are the people that have higher association with socioeconomic factors compared to the other groups. But then what's the mechanisms? Why transferring money to people actually prevent them from being a suicide victim? For the Bolsa Família program, we have three hypotheses, three pathways. The first one is by generating income. Generating income, you can expect a reduction in socioeconomic hardship and decrease of stress decrease, relief. And you can also expect that after transferring the money, it would increase hope and self-esteem and increase stability in the households. The studies have also showed that by generating income, you reduce predisposition to mental disorders such as alcoholism and depression. So previous studies have showed that receiving the cash transfer decreases the alcohol intake in those households. The second pathway is by increasing inclusion, what increases social welfare. And the Brazilian program has conditionalities. And through these conditionalities, there are studies showing that receiving the Bolsa Família increases the access to education. This is also an intersectoral program. So combining with receiving the money, there is a parallel program that offers skills and trainings to people to increase the chances of them getting employed. This part of the program is called productive inclusion, that aims to help people to be trained, have skills to get a job, and all of that increases social welfare. The second conditionality is related to health services. So for women who are pregnant, they have to attend all the medical appointments. If they have kids, after having the kids have to follow up with the vaccination. And all of these have been increasing access to services, including access to mental health care. Once the person have more access, people have more access to health, to services, to mental health and health services in general, it increases the risk assessment and also the chances of getting support when needed. And all of that is increasing the human capital and therefore the social welfare, and therefore influence the behavior, including the suicide behavior. So what we are talking here basically is that this program, the cash transfers programs, they are interfering in the basic needs. If we link that with the Maslow pyramid, for example, Maslow brings to us the idea that for human being goes to the psychological needs, it would need first match the basic needs. So imagine that if you only intervene through the mental health care assistance, through psychiatric or psychological, when the person has not even had the basic needs matched. So imagine giving a psychiatric pill to someone that has not even managed to have security, safety, food, water, the basic needs matched. Another interesting pyramid that help us to understand the effect, the impact, the possible impact of these cash transfers is the framework for public health action that will tell us that increasing population impact when you move to the bottom, and it will increase the individual effort needed when you go to the top. So when you interfere in the socioeconomic factors, you have higher potential for population impact. And the third one is the optimal mix of services, a whole pyramid framework that tells us that the frequency of need, it decreases when you move to the top of the pyramid, and also the costs increase. So if we intervene at the base of the pyramid, the cost might be lower, and we might prevent people from getting severe and needing actually specialized care, which costs way more. This is very important literature review paper showed us a causal mechanisms and show a causal evidence that links poverty with mental health problems. So basically, poverty increases worry, physical health, decreases physical health, increases worry, increase early life conditions, and increase exposure to violence, crime, and decrease the social status. And all of that increase the chances of mental health problems, while mental health problems also impacts on productivity, labor supply, preference, economic decision making, and all of that can make people even poorer and stop them from having the chance of getting better socioeconomic situation. So the only way of actually trying to stop this cycle that feeds itself is by intervening with social economic interventions, such as cash transfer programs. So in sum, what I would like to say is that ending poverty would likely alleviate the strain on scarce sources for mental health treatment. And that will impact on people, on services, decreasing the need for more specialized care in our facilities that are already very overwhelmed in most of the parts of the world. It would decrease the costs in these facilities as we would have less people actually seeking for this help. And it also results in lower rates at the population level. But all of that is not without a challenge. So there are a few challenges when we think of implementing these programs in low-middle-income settings or even high-income countries. And those challenges are related to feasibility. For example, how to guarantee enough funding. And one of the strategies to deal with that is revise the budget to make sure the budgets are allocated for the most urgent needs. In Brazil, to deal with that, the program was transformed in a national policy. So a certain amount was canalized for this program specifically. The second challenge is related to implementation, which is the definition of the target population, coverage, conditional or unconditional. For the target population in Brazil, we have a cutoff point. And so people have to receive up to 70 or 140 if there is a pregnant woman or a child, a family member. Regarding the conditional or unconditional, I would say it depends on which context you are talking about. For Brazil, for example, in Brazil, there was a urgent, still there is a urgent need to remove the kids from the street. And so the conditionality to bring the kids to school and for them to attend the classes is very important to target this problem, but we would need to evaluate each context. And there are also challenges related to access, how to guarantee that the most needed people actually access it. Because the most vulnerable people, they generally have less access, they are living in remote areas. So those are the people that most need it, and while they are the people that most need it, they are also the people that tend to have less access. So for Brazil, to target that, we applied active search. So we had community workers going to the houses and not waiting for these people coming to the services, but the community workers were going to the house and knock there and try to find them. So there was an active search. And we also can expect challenges with scaling up, especially in countries with millions or billions of people. And for that, in Brazil, we used a unified system with online data record. And then finally, I would like to leave with two takeaway messages. And the first one is that suicide is a multi-causal phenomenon. Therefore, we couldn't expect that only one intervention would be able to make impact at the population level. We actually need intersectoral strategies to target many of the problems, and cash transfers may be an important strategy to reduce suicide. Thank you very much.
Okay, on behalf of the organizing committee, I'd like to thank Dr. Diane Machado for sharing that fantastic presentation, which really explains very lucidly the mechanism of cash transfers in providing mental health support and in reducing the risk of suicide. And of course, the study that was done in Brazil had some fascinating insights where they witnessed a reduction of 60% in risk of suicide. And I'm sure there are lots of learnings for both India and other low middle income countries to adapt cash transfer programs as a strategy for supporting people with mental health problems and also for reducing the risk of suicide. In case there are any questions for Dr. Diane, then I would request you to put them in the chat box with your email ID. We will send these questions to her and then forward the responses back to you. So feel free to put your questions in the chat box, but please do also mention your email ID so that we can get back to you with her response. Moving on, if we can move on to the next sort of sub-thematic for this session, which is gender and suicide prevention. Of course, if we look at India's context, we do know that suicide rates are extremely high among cis women. In fact, suicide rates among cis women in India rank much higher as compared to the global average. We also know that women who experience domestic violence are 3 to 7 times more likely to attempt suicide. So there are very strong correlations between gender and suicide. And we'd also like to explore what are some of these correlations and what are some of the strategies that we can address we can sort of use to sort of address the problem of suicides amongst in sort of gendered communities. And for this, I'd like to sort of introduce our next speaker, Dr. Lakshmi Vijay Kumar, who is the founder of Sneha, an NGO in Chennai for the prevention of suicide. Dr. Lakshmi is also the head of the Department of Psychiatry, Voluntary Health Services, Adyar, Chennai. She's also a member of the World Health Organization's International Network for Suicide Research and Prevention. She's also an honorary associate professor in the University of Melbourne, Australia. Dr. Lakshmi was one of the editors of the WHO's report on preventing suicide, a global imperative, which was published in 2014. Dr. Lakshmi is also one of the key persons who was responsible for the drafting of the recently notified National Suicide Prevention Strategy for India. Dr. Lakshmi's areas of interest and expertise includes developing cost-effective community interventions to prevent suicide. So Dr. Lakshmi, thank you so much for being a part of this session. And if I can hand over to you, you have 10 minutes to make your presentation. Yes. Thank you.
Thank you, Arjun, for the introduction, and thank you all for inviting me to this important meeting. And it's a pleasure to be here. And as Arjun said, we are just 2 weeks back, the Ministry of Health, Government of India has put the National Suicide Prevention Strategy in its website. And we do hope that it gives an impetus to suicide prevention because it delineates all the activities and implementations and the monitoring which can be done by multiple sectors of people. And I think the strategy is multi-sectoral and inclusive and has something for everybody to work on. So I hope this provides a platform for a lot of us to work more effectively to reduce suicides and save lives in India. Coming back to the issue of suicide and gender, it is a kind of a paradox because it is if you look at it, we have always said that depression and suicide go hand in hand. And everywhere in the world, if you look at it, the prevalence of depression in women is higher than men. Okay. But if you look at the suicides, in all the countries of the world, men die by suicide more than women. So this is a kind of a gender paradox, and people don't really know why this is happening. And there are various reasons for that. The various reasons are, it could be the method of choice of the to die by suicide. It could be an early help-seeking behavior of the women so that they are treated effectively. It could be the fact that the women's suicides are underreported. So many other factors are there. But if we come to suicide and gender, if you really look at it, I think the discrimination and of female gender starts right from the womb. I think, I'm sure all of us are aware of Amartya Sen's statement that we are missing at least so many women every year, because India has very, what shall I say, very bad statistics of less women when compared to men, unlike other countries. So the gender ratios are very, very not in favorable for our country. So the discrimination starts at the womb itself. And then if you look at the specific factors of violence in women, we know that child sexual abuse is associated with 16 times the number of suicidal behavior in women when they are in adolescent or even in adult life. Okay, so child sexual abuse, what happens when child sexual abuse happens is that the girl child loses trust in a relationship, because most of the abuse happens at home with known people, we know that. So there is an inability to form trusting relationships. So that inability to form trusting relationship translates through their life, and they make wrong choices of partners, and they get caught in toxic relationships, and then ultimately we label them as borderline without understanding the mechanism of why they are feeling this way, where they are not able to form attachments, where they are not able to find trusting relationship, where they are feeling insecure. So child sexual abuse, exposure to violence at a young age has consequences for the girl child right through her life. And we know that depression is increased, and suicide is also increased in when you're exposed to child, child sexual abuse. And then when we come back, if you look at the life cycle of women, then you come to say adolescent age group. And actually, if we look at it, the suicide is the #1 cause for death in India for girl children between the age of 18 and 29. Okay, it is not maternal mortality, it is not traffic accident, it's not infectious diseases, malaria, whatever it is. It is suicide, which is the #1 cause for mortality. So why is it that this happens? See, because if you look at the young adolescent, the young girls, we find that, let's take, for example, the issue of marriage. In many countries, marriage is considered as a protective factor. It protects you from dying by suicide. But in our country, actually, we find that marriage, not only in India, but in China and in many South Asian countries, particularly for a women below the age of 30, actually being married has twice the risk of being suicide. And why is that? And that is because if you, for example, the early marriages, 40% of girls in India are married by the age of 18. 60% of the girls are married before the age of 18 in Bangladesh, Afghanistan, and other countries. And in Bangladesh, Afghanistan, and Pakistan, about 50% of the girls are married below the age of even 16. So when you're married at the age of 16 and 18, and many of these marriages are arranged marriages, and particularly in Afghanistan, the issue of forced marriages are extremely common, where women are used as bartering tool, for reducing the poverty of as a repayment of debt, or as a to bring peace between the tribes and so on. So the women are being used as a commodity. And even in India, I'm sure we have all read about this honor killings, as though a woman's life is not her own and it is a property of somebody else. And the lack of choices which she faced. It's not surprising that many young women find life feel trapped in a marriage, in the early marriage, forced marriage, and many of them have looked for, felt life is not worthly. And if you look at, even if you look at the Durkheimian theory of suicide, he calls it as fatalistic suicide, where you feel you are trapped in a situation from which you cannot escape, and you're trapped in a difficult marriage, trapped in from a marriage from which you can't get out, and where the society doesn't allow you to get out, is an important precipitant factor for suicidal behavior in women. And also, I mean, when you talk about marriage, it is not only early marriage, arranged marriages, and forced marriages, but it's also denial of being allowed to marry somebody whom you love. I mean, you don't come across love failure in other countries, in the non-South Asian countries, where women are not allowed choice of their whom they want to marry based on their status, caste, society, religion, and so on. So that also has an important factor. And then we come to, after marriage, also the issue of domestic violence and intimate partner violence. It is really sad. There has been a population-based study in India where we find that where more than 10,000, 12,000 women stratified across various cities were interviewed, and it was found that 64% association between intimate partner violence and suicidal ideation. And that's a huge factor. I mean, the intimate partner violence and domestic violence is prevalent in many countries. It's not that it is only in India, but the association is much more in India than in many other countries. And that is a sad state, because it is to a large extent culturally condoned. And unless we change the narrative of this, and it has become even obvious for us during the COVID times, when there were they couldn't even escape. In fact, we had many calls to our call center in Sneha, where the women were abused, and before they could go to their friends or mother's family or travel somewhere, and that became impossible. So they were really trapped. They could not get out of the house and had to face the abuse every day, and many of them in front of the children. And it's not surprising that the domestic violence increase and the suicide in women also increase. Suicidal behavior among the women also increased dramatically at that time. Home was not a homes for women with facing domestic violence. Home is not a sweet home. No, there's no home sweet home for them, unfortunately. So we don't have safety nets. I mean, it has happened in other countries also. For example, it happened in Canada. And the Canadian government actually booked a series of hotels in many places so that women could escape from there and stay in the hotel, have a reprieve from the everyday facing violence. So that is an important factor. The tragedy here is that we, on one hand, we have some strategies for reducing domestic violence. We have some strategies for reducing suicide, but we don't have something which combines both. And that is a sad state of affairs. We do not have an integrated model for reducing domestic violence and intimate partner violence, and in the context of suicide prevention. So these two have been silos, and we need to bring both together, because unless we handle both. And the third factor in this is, of course, the use of alcohol and substance abuse, which these three are interrelated and correlated. Alcohol abuse, substance abuse, domestic violence, suicidal behavior is like a cycle. It's a vicious cycle. And unless all three are handled, we will not be able to make any headway here. And that is the need of the hour. Then when we come to older women, the older women, even though they may not face violence as such when they are a little bit older, because by that time, majority of them have become matriarchal and things like that. But the fact is that even at that age, women are expected to contribute to the family. Even if you're old, men retire, women never retire. And that is the tragedy, because many women find it difficult to contribute to the family as expectations at that time, and many of them feel depressed at that time. The fact that so has things been changing? In fact, a recent Gallup poll has shown that the women in India have become angrier in the last 10 years. And it is not surprising, because the women are, more and more women are educated, but still they have to listen to a patriarchal system, and they feel frustrated and constrained by the society, so they have become angrier. And when you become angrier, you can express it outside, or like many women, you internalize the anger, and that translates into suicide. So suicide is sometimes considered as murder at the 180th degree. It's a internalized anger. So you can't show anger outside, you turn it on yourself, and you die by suicide. See, the fact is, what can be done to change this? We have to have more and more educated women. The fact that even if you look at the statistics of people who have failed in exams, okay, below the age of 20, it is more girls actually. Because if a boy fails, he gets a second chance, third chance. But if a girl fails, that's the end of her studies. And so she feels hopeless about her future. So education and economic independence, that's crucial for a woman to feel self-worth and feel that she is a contributing member of the society. And that is important for increased self-esteem and hope for her life. I am coming to the end of my 10 minutes, and before Arjun cuts me off, all I want to say is that I think we are all privileged women, because we are here sitting talking about women's rights, domestic violence, and everything else. But for each one of us, there are hundreds and thousands of other women who have not had the kind of support or privileges or opportunities which we have had. And it is important for us to reach out to them. Having said that, in spite of all the odds, women have progressed. Nancy Reagan had a nice quote. She said, "A woman is like a tea bag. The more the hot water is hot, the stronger she becomes." So we have faced obstacles. We have faced difficulties, and we have been able to make a difference. But it's only a few of us, and it is our responsibility to reach out to the other women who have not had our opportunities and help them. Thank you.
Thank you, Lakshmi. You've really, in a short time, really packed a really complex issue with such clarity. Thank you for really sort of giving us a bird's eye view on some of the intricacies involved when we're looking at the relationship between gender and suicide prevention. What particularly stood out to me, and I was also thinking about this, was looking at the idea of integrated models, and we look at domestic violence as a separate issue, and we look at suicide prevention as a separate issue. And I think the heart of intersectorality in that sense is really calling us to change our notion of how do we want to address both these problems, not as separate issues, but as two very integrated issues which have an impact on each other. I know you've had a very busy day, Lakshmi, so thank you so much for taking the time, and please just stick around because we might have some questions at the end of it. Let's move on to the next sub-theme for today's session, and that is really looking at the role of data and suicides. Now we know that official data on suicides in India is collected by the National Crime Records Bureau. And we're also aware of the fact that the data collected by the NCRB is actually a gross underestimate of the actual number of suicides in India. And this ranges from anywhere between 30 to 75%. So there are huge issues around how data is collected on suicides, and also the importance of data for us to understand suicide as a complex issue, and also design evidence-based strategies which can really look at suicide prevention. In this regard, I'm extremely honored to welcome our next speaker for today, Dr. Rakhi Dandona, who is a professor at the Institute for Health Metrics and Evaluation at the Public Health Foundation of India. Dr. Rakhi is the chair of the Global Burden of Disease Study Injury Expert Group for the India State Level Disease Burden Initiative. Dr. Dandona has experience of over 25 years in large-scale populations and hospital-based injury epidemiology studies, in particular for road traffic injuries, suicide deaths, drowning, and gender-based violence. Dr. Dandona is also a member of the Lancet Psychiatry Standing Commission on the COVID-19 pandemic and mental health, and a steering committee member for the International COVID-19 Suicide Prevention Research Collaboration. Dr. Dandona is going to be talking about the theme, improving data surveillance systems for suicide prevention in low middle income countries. It's an absolute honor to have you, Dr. Rakhi. Over to you. You've got 10 minutes. Thank you.
Thank you very much, Arjun. I'm very pleased to be here. I'll just share my screen. Can you confirm if you're able to see my screen?
Yes, we can see it.
Perfect. Thank you very much. Thank you for this opportunity, Arjun. I've enjoyed the talks so far very much. I will talk about data surveillance systems for suicide prevention, more in the practical sense of where we need to go to start looking at better. We've had many calls to action for India, specifically to better count and improve surveillance for deaths by suicide, and some also by self-harm attempts. Much less than suicide deaths, given that we still have a huge number of deaths to take care of. I will take you through this presentation by looking at what data do we actually mean. More often than not, the data that we talk about is restricted to number of deaths. And that's typically what we talk about NCRB, underreporting the number of deaths by suicide, or for other injuries for that matter. But the data that we're looking for is beyond the number of deaths. It also includes the cause of death, the demography of the people who are dying, the method for death, and the reasons for that. This together is what would form a good surveillance for us to take action to prevent these deaths. I'll start by number of deaths and cause of death. As many of you know, across the world, there are vital registration systems in all countries, including India, They are mandated to document birth and death. So when we have a birth, there's a birth registration system. When we have a death, there's a death registration system. If you've had a death in the family, you would know that you would have to notify that death to the vital registration system, and a death certificate is issued. And for each death that happens, there has to be a medically certified cause of death. And this process is also laid out for a country like India. However, our challenge is that our vital registration system, which is also called a civil registration system in India, is grossly inadequate. This was a global assessment of vital registration systems around the world, published in 2020. India is in red, which means that our capacity of a vital registration system to record births and deaths and cause of death is actually pretty low. And we are in red mainly because of deaths, the number of deaths and the cause of death. And I will highlight a bit more on these two in this presentation. The number of Indians who die every year, unfortunately, continues to be an estimate. So we have the deaths that are registered with the system. So this is everybody who went to the system to get death certificate, which is your numerator. And the denominator is an estimate that's based on sample registration system. I won't get into those details, but it's important to understand that we do not have a good number, a correct number of Indians dying every year. And this, unfortunately, hasn't really changed over time. Of all deaths that happen in India in a given year, about 21% of these deaths actually have a medically certified cause of death. And this is the latest proportion for that. And if you see states where you have really large population in India, all these states down here, the proportion ranges from 5%. So Bihar has only 5% of all deaths that happened in Bihar in a given year actually had a medically certified cause of death. And it goes all the way to 100% in Goa, which means that our estimate for the number of Indians who die is an estimate, and only 20% of those numbers actually have a cause of death. And this is important to keep in perspective when we talk about deaths by suicide. So what happens in India is to arrive at where the priority setting for India for cause of death is. We are then down to extrapolations. Extrapolations using sample registration system, the deaths that have a medical cause of death, and all of this is put together, for example, by Global Burden of Disease study, which I deal with, or the WHO estimates, trying to understand how many Indians died and of what causes. The self-harm and violence is down here at 11th rank, if you look at all ages. And this is why we are dependent on the police records as part of the National Crime Record Bureau. Most of you present today would know that NCRB records it as accident and crime. Intentional injuries are recorded as crime, and unintentional are recorded as accident. Specifically for suicides, a few years ago, we kind of we matched the number of deaths, suicide deaths, in police records with that estimated by GBD. And we kind of showed, the extent of underreporting by the state. So as you can see, these states have a higher level of underreporting, urgently due to this underreporting. But again, it's important to know that this underreporting, what we've shown here is an average. It changes by the year, it changes by district. So there's underreporting variation within the district, between the districts, and over time. So it's very difficult to say the extent of underreporting could be, a straight line for a given state for a given year. We took this underreporting a bit more in detail recently. We undertook a large household survey in UP and Bihar. And these are the states where, as you saw, the underreporting is fairly high and are one of the most populous states for the country. A large population was covered in both the states, and we looked at deaths in the last 3 years, that was 2018 to 2020. What was interesting was that we found underreporting between those in the household survey that ranged from 25 to 40%, which meant that these deaths were not missing in the NCRB. So these deaths were not reported to police at all. So there is your underreporting within the police system per se, which is the system that we use to understand the number of deaths in the country for suicide. And interestingly, only 1/4 of the suicide deaths actually had a death certificate, which meant that 3/4 of these deaths were underreported in the vital registration system. So this is important to understand that the underreporting is of two different ways. One is to the police, but one is to the larger system, which is counting the number of Indians who die each year and the causes by which Indians die each year. A variety, we looked at which deaths get registered and which don't. Not surprisingly, male deaths, higher wealth index, those who are employed, wherever there was a financial benefit involved, those deaths are more likely to be registered, which is what we know. But this was a large-scale evidence that we generated for India, for UP and Bihar. And this was also very interesting. We saw this in Bihar and UP both, irrespective of the age that you look. This is combined, which is the death registration irrespective of male death or a female death. This is the male death, and the blue one is the female death. So irrespective of the age that you look at, age at death, the female death registration continues to be low irrespective of the age. So clearly highlighting the gender underreporting, not only for suicide deaths, but for all deaths in India. So suicide is part of that gamut of underreporting of deaths for women in India. So what's important to understand is that both police records and vital registration system are passive forms of surveillance, which means that the police is not looking out for suicide deaths, is not looking out for road traffic injury deaths, for example. It's the cases that get reported to them. Similarly, for vital registration system, it is the deaths that get notified to the system. If the family comes for a death certificate, gets notified. So what it also means is that if we really need to change the way the numbers are in our system, if we really need to get a sense of how many people in India are actually dying by suicide, as a community, we need to do our bit as well. We need to make sure that these recordings happen. Of course, there's a big, we can talk a lot about, why these deaths don't get registered, but it's important that we start talking about the fact that it's a two-way street. If the system needs to work on it to make sure that, the crime part of it disappears in practicality, it's also on the community to make sure that the deaths that we have, irrespective of the cause of death, actually have a death certificate so that we can start counting these deaths and cause of death better. The other aspects of data surveillance are the demography, who dies, age, sex, occupation, education, how these people die, and the reasons for death. We do use NCRB for this, for understanding of this better, given that we do not really have many large-scale community surveys done year after year. There are some community surveys, some health facility surveys, and media reports also help us to get some sense of who's actually dying by suicide. But predominantly, it's the NCRB reports that we are dependent upon. These pie diagrams directly come from the NCRB reports. This is the educational status, the distribution, the proportion of all deaths, suicide deaths that got reported in 2021. This is the distribution of those with or without education, and this is by the occupation. Now, what's interesting is that many times the interpretation for these pie charts is typically done to say that 11% of those who died by suicide in India have no education, which is fantastic. But this is 11% of this 100 who've died. This 11% could actually be very different at population level, depending on how many people at that population level are actually illiterates or have no education. So that interpretation at population level is very important for us to use NCRB data to understand where the interventions need to be. We cannot simply assume this 100% and make interventions specifically for these groups. And that's what's lacking currently within the public health space for suicide deaths in the country. I'll give another example. The reasons. NCRB, as I said, is the predominant source for reasons. family problems account for 1/3. And there's love affairs and there are marriage-related issues. The problem is just knowing family problem as a reason doesn't really help us to understand where to intervene and how to intervene, because the family problem for someone who died in state A, district A, would be very different from a family problem that happened for someone else somewhere else. So the standardization is needed for having a reasonable interpretation. So this is what we can do with the police data. There are injury surveillance guidelines. There are standardizations available as what we mean by family problem, which means that if there is a case of suicide death in Kerala, and the reason there should be recorded exactly the same as a similar reason in, let's say, Bihar. And that's the challenge that we have, because this reasoning really doesn't help us to understand where do you start to tackle family problems to take care of these deaths. Illness is another example. We need to know beyond illness. Is it the illness that has no treatment? Is it the illness that involves a lot of pain? So those are the kind of details we need to understand in the data better for us to plan interventions. This is my last slide, just to say that this is how the probability of India looks like. If we continue with the current trends, we are not likely to reach the SDG goals in 2030. And actually, we're going to be more red than blue, which is unfortunate. But we really need to now start talking about the fact that we really need to look at the community level to make sure that all the deaths are registered. We need to look at the system level to make sure that the cause of death for most of these deaths is recorded. We need to work towards standardization in the police records and using correct interpretation of NCRB data at the population level for interventions for the suicide deaths to look very different than what you see in the red map here. Thank you very much.
Thank you, Dr. Dandona. This has been a really fascinating presentation, and for me, it's also been really sort of interesting to learn some of these facts. I mean, 21% of deaths in India are only 21% are medically certified in a country of the population that we have. It's quite staggering. But I think what also has sort of stayed with me in all the things that you've shared is also the role that the community needs to play. I think that's really fascinating, and I think one such model has sort of we've sort of developed this at the Center for Mental Health Law and Policy and the Suicide Prevention and Implementation Research Initiative, where we've actually designed a community surveillance system in the district of Mehsana and Gujarat, which has been working quite well, and we've also published a paper on that, and happy to share that with everybody. But I think that's a really critical point in terms of how the community actually needs to step in from an active point of view, because the actual data which is being collected by the police is actually passive surveillance, which really doesn't help and give us the answers to why we have such high suicide rates in India and differential suicide rates across different demographic groups. Thank you very much, Dr. Dandona, for a fascinating presentation. Let's move on now to the final webinar for today. So the theme of today's conference for day one of the conference is changing mental health paradigms. And I think one of the things that has been sort of repeatedly sort of emerging from the first session onwards with Dr. Rochelle Burgess and the panel discussion, and even some of the discussion that Dr. Lakshmi and Dr. Rakhi have pointed out, is of course how do we sort of engage lived experiences or the community in sort of mental health and suicide prevention research, right? And the question really is in terms of who is setting the research agenda? How is the research agenda being set? What are the questions that are being asked? Are these even relevant questions? And that really brings us to the question of how do we engage lived experiences in suicide prevention research, especially when we're looking at diverse demographic population groups. We're looking at a plethora of intersectoral evidence-based strategies addressing a range of socioeconomic issues that contribute to suicides. And in this regard, I'm again very honored to to sort of welcome our final speaker for this session, Tanmay Goswami, who is a user survivor and founding editor of Sanity, an independent mental health journalism platform based out of New Delhi. Prior to this, Tanmay worked as the world's first Sanity correspondent at The Correspondent, which was headquartered in Amsterdam, writing about politics, economics, and the culture of mental health. As part of his own lived experience advocacy, Tanmay has been co-facilitating suicide reporting workshops for journalists with the Center for Mental Health Law and Policy. Tanmay is also currently researching a book on India's mental health movement. Tanmay is going to talk about the theme centering lived experiences in suicide prevention research. So over to you, Tanmay.
Thank you very much, Arjun. I'm very happy to be the final speaker because that means I don't have to feel pressured to finish in exactly 10 minutes lest I delay anyone else's presentation. I'm going to try and share screen and please do give me a thumbs up if you can see my screen.
Yes, we can see it.
Okay, fantastic. All right. So thank you, Arjun, once again for introducing me. I would like to introduce me a little differently, so I beg your indulgence. I am, as Arjun said, the creator of Sanity, which is an independent mental health storytelling platform. This is actually my business card. So the reverse of my business card is what I'm more interested in sharing with you. I am a lived experience expert. I also like to think of myself as an anxious partner, a fumbling father, and of course, I'm a pill popper, I'm a therapy worshiper, and finally, I'm a suicide prevention advocate, and those are my coordinates. I'm also currently a fellow at the RISJ at the University of Oxford, where I'm researching best practices for media reporting on the economics of mental health in low and middle income countries. And I was very fortunate to be the co-author of a paper in the Lancet Psychiatry on the National Suicide Prevention Strategy in India with Dr. Dandona, Dr. Vijay Kumar et al. And funny story, when the Lancet published this paper, they emailed me the PDF of this paper. And the first line of the PDFs of the email said, "Dear Dr. Goswami, we are very honored to publish your thoughts, etc., etc." And I had to actually write to them saying, "Hello, I'm not Dr. Goswami, I'm Mr. Goswami." And I think that kind of holds an important clue to the kind of expertise that the world expects. When you are part of prestigious platforms such as the Lancet Psychiatry, the world expects doctors, not misters. And finally, I am a cisgender, heterosexual, middle class, upper caste, majority religion, English speaking man. So I kind of tick all the boxes of privilege, except I'm not white. Let's look at what lived experience actually means. It is, according to one article, James and Smith's in The Spectator, it is translated from the German Erlebnis, and it can be traced back to The Second Sex by Simone de Beauvoir, where de Beauvoir argues that in order to answer the question, what is a woman, one had to dig much deeper than mere biological characteristics and look at stuff that was hard to quantify in purely objective terms. So there you have important clues already as to what lived experience is about. It is freedom from purely objective information. It also pushes you to dig deeper than mere biological characteristics. Now, from that feminist sort of genesis, this is quite fascinating. Here is a job description for head of lived experience at the mental health charity Mind. Candidates for this role will have a personal, direct experience of mental health problems with substantial experience of integrating this experience into your day-to-day work to inform your values, communications, and approach to lived experience and community leadership. Sounds like rocket science to me. And then James and Smith in the same article says, here, lived experience, however traumatic, is touted as a form of career currency to put on your CV, just as you would a degree. A lot to think about in that. I have to tip my hat to the UK's first mental patients union, which was created exactly 50 years ago as a response to the fact that lived experience experts were chronically neglected in criticisms of the mental health establishment. And particularly, I'd like to draw your attention to that illustration, which is taken from the cover of the manifesto of the union. And I'll read the paragraph that accompanies the illustration. It says an individual having unusual difficulties, sorry, for people with accessibility needs, the cover shows a fish writhing at the end of a hook. An individual having unusual difficulties in coping with his environment struggles and kicks up the dust, as it were. I have used the figure of a fish caught on a hook. His gyrations must look peculiar to other fish that don't understand the circumstances, but his splashes are not his affliction. They are his effort to get rid of his affliction. And as every fisherman knows, these efforts may succeed. Carl Menninger, the psychiatrist, wrote this. And of course, he uses the male pronoun predominantly. I think we can transpose that onto any gender, and the spirit will still stand. Let's understand what lived experience is not. So the two things to remember here. Lived experience is not some kind of certificate, right, that you get after completing a diploma. You can't tether lived experience to a diagnosis or something tangible written on a piece of paper. This is a particularly big problem in suicide prevention. As Dr. Dandona pointed out, we have rampant underreporting, so there is often nothing written on paper. Also, the other thing is, which is not very intuitive, from my own experience and when I speak to people, a lot of them live with suicidality and imposter syndrome. So we ask ourselves, do we really qualify if we are still alive and speaking to this August gathering, and I don't have bodily scars anymore to show for my pain? Mass media is, of course, only interested in reporting the most shocking or sensational cases. And as a culture, we have created a hierarchy of suffering. This means the vast majority of people will never meet the benchmark and will therefore never occupy space in meetings such as this. And secondly, some experts by training feel that when we say lived experience is a form of expertise, we are merely talking about one individual's subjective experience. No, we are in fact talking about the vast body of collective wisdom that the mental health orthodoxy has ignored for centuries. Now, the question is, if we have to tap into that body of collective wisdom, how do we create space for people who don't look like me or talk like me, and who are not able to manufacture a coherent PPT out of their pain and suffering? The other common myth is that lived experience is just soft expertise. That means we are experts on soft themes, such as our struggles, our feelings, our emotions. But here's the thing, a person living with a chronic illness, for instance, can also be an expert on the distribution chain of a rare drug. That's hard expertise. During long COVID, we saw, including my friend Priya Kamal, who is the founder of Suno India, India's first podcasting platform, she had to do so much interpreting of scientific research. She had to take that to her doctors because nobody was taking her seriously, since our understanding of long COVID in the early days was very limited. And long COVID, there have been stories out there of women particularly dying by suicide because their long COVID symptoms were not taken seriously in the early days. None of this means that lived experience experts want to compete with or completely dismiss conventional experts. We still go to qualified healthcare professionals. It only means that we want to be treated on a par. We seek a complementary relationship, a partnership. Nothing about us without us is ultimately a power struggle between ordinary people and trained elite experts. I want to tell you what that struggle feels like sometimes from the former's perspective, from the perspective of ordinary people, ordinary experts. And unfortunately, this has mutated into some kind of a culture war between big T truth and small T truth, where lived experience experts occupy small T truth and experts by training occupy capital T truth. And when I talk to people, the feedback that I get is, yeah, sure, now the world grudgingly tolerates us, but it still does not really respect lived experience. The most common refrain we hear is, sure, lived experience is a form of expertise, but subjective experiences should not replace empirical evidence. There you go. There's that angst again, that somehow we are seeking to, dethrone empirical expertise and empirical evidence, whereas what we are demanding really is complementarity. This is an interesting book called The Death of Expertise by Tom Nichols. This is rooted in the American reality during the Trumpian years. But I think this particular paragraph is interesting from a New York Times review of the book. The death of conventional expertise is part of a larger wave of anti-rationalism. It shows the growing ascendance of emotion over reason, the blurring of lines among fact and opinion and lies, and denialism in the face of scientific findings about climate change and vaccination, for instance. Another article, We are likely to make gross moral errors when we consider lived experience as all there is to knowledge. The appeal to lived experience has polarized modern society into two warring camps. The in-group, who are the victims of oppression, apparently the in-group thinks that they're victims of oppression, and the out-group, who don't have that experience. We apparently see them as oppressors for whom maintaining the status quo is a priority. And the author ends with a very, very serious warning. The consequences for democracy are dire. When I read these articles, this is what I register. So what is lived experience equated with? Emotion over reason, denialism, opinions, lies, ignorance, fragile egos, gross moral errors, and finally, threat to democracy itself. And it makes me wonder whether lived experience is basically a weapon of mass destruction. Meanwhile, this is what mainstream mental health expertise can look like, right? So that box is taken from James Davies' book, Sedated, where he describes what one member of a DSM committee said about how the DSM diagnostic categories actually come into existence. One person says, I feel like Chinese food. Another person says, no, I'm really more in the mood for Indian food. And finally, after some discussion and collaborative give and take, they all decide to go have Italian. And of course, we know psychology has a weird problem: Western, educated, industrialized, rich, and democratic. Basically, a lot of psychology research is done on North American college students and then extrapolated as representing the entirety of human experience. Finally, I believe that a lot of the cultural unease around lived experience as a form of expertise comes down to this. This is another article where the author says, now, the only required response when someone decides to share their truth and see that this is the small t truth is to sit in silence and listen. That really is what defines the unease, right? Like, lived experience experts are now demanding that others sit silently and just listen to us. Listening to lived experience means undoing epistemic injustice. But here's the thing to be wary of. The expectation that lived experience experts must also be advocates. This is a pernicious one that feeds the good patient, bad patient narrative. There is power in advocacy, but that cannot be used to justify the burden that we should constantly prove and, even worse, perform our expertise. Lived experience is not just a tick box. So to all the researchers in the room, if you only involve lived experience experts on panels such as this or on papers that extol lived experience, but you don't actually include them in research design, fund allocation, impact measurement, you basically don't believe that these people have real expertise, what I called hard expertise a few slides ago. You are just ticking a box to look good, or because your, the grant givers these days are mandating that you need to have a lived experience person as a co-PI. That's the only reason you're doing this. And finally, if you look at that box to the right, sorry about the wonky formatting, this is from the Suicide Prevention Resource Center. And this is why the center believes that it's important to include lived experience voices. They can serve as models of hope. They can be extremely valuable in prevention planning, treatment, education, etc. And they can help you to better tailor your approaches to meet the needs of those with whom you're working. But lived experience experts don't owe the world hope or inspiration. Don't include them because they can add value to you or to your research or help you better tailor your grant proposals. Include them because you have the power to do so. Include them because it is the right thing. Thank you for listening.
Thank you, Tanmoy, for being as provocative as you always are, and for really pushing us to really question our fundamental assumptions and rationales around what is lived experience, and how do we really integrate lived experience in mental health and suicide prevention research. I think that was extremely compelling, and I think it probably forces everybody in this room to really think about what we understand by lived experience and what is our engagement with lived experience and what is the positionality and the place that we are engaging with lived experience. So thank you for that. I'm afraid we are at time, so I'm not sure we will be able to take questions because I think our speakers for the next session are already here. So I think we can take a break for about 5 minutes because this has been quite intensive and heavy. So maybe we can convene back at 6:10 or 10 past 6. And I can assure you a very exciting session up ahead with Dr. Awais Aftab and Dr. Soumitra Patare. But again, on behalf of the organizing committee, I'd like to once again thank Dr. Lakshmi, Dr. Rakhi, Dr. Diane Machado, and of course, Tanmoy for delivering absolutely spectacular and extremely informative and thought-provoking presentations. In case anybody has questions in the audience, please do put them down along with your email ID. We will facilitate and communicate these questions to the speakers and sort of ensure that the responses come back to you. Thank you once again, and see you at 10 past 6.
Welcome all. I know it's a short break you had of the long day, but this is the last session of today, of day 1. And I'm happy to introduce to two people who are going to conduct this session. Before I introduce them, the topic of this session is interesting. It's contemporary debates in psychiatry, from clinical diagnosis to recent advances. And the format is going to be Dr. Soumitra is going to interview Dr. Aves and try to get through get through in depth for this topic. What I will do is I'll introduce Soumitra and Aves first, and then hand it over to Soumitra to begin with the session. Dr. Soumitra is a consultant psychiatrist, the director of the Center for Mental Health Law and Policy, Indian Law Society, Pune. In the past, he has provided technical assistance to the Ministry of Health and Family Welfare, Government of India in drafting India's new Mental Health Care Act 2017, which takes a rights-based approach to mental health care. He was also a member of Mental Health Policy Group appointed by Government of India to draft India's first national mental health policy released in October 2014. He has served as a WHO consultant in many low and middle income countries, assisting them in drafting and implementing mental health legislation and national mental health policy. Soumitra is also the lead and co-leads on various projects on suicide prevention. Welcome, Soumitra, and thanks for this, agreeing for doing this session. I'll now introduce Aves. Aves Aftab is a clinical assistant professor of psychiatry at Case Western Reserve University, Cleveland, OEO, United States of America, and a staff psychiatrist at North Coast Behavioral Healthcare. He completed his psychiatric residency from Case Western Reserve University, Cleveland Medical Center in 2018, and geriatric psychiatry fellowship from University of California, San Diego in 2019. He has received numerous national awards and honors, including prestigious Laughlin Fellowship by the American College of Psychiatrists and American Psychiatric Association Leadership Fellowship during his psychiatric training. He leads the popular interview series Conversations in Critical Psychiatry for Psychiatric Times, and a book adaptation of the series is forthcoming from Oxford University Press. He is an associate editor for Current Psychiatry, senior editor for Journal Philosophy, Psychiatry and Psychology, and he has been actively involved in initiatives to educate psychiatrists and trainee psychiatrists on different controversies in psychiatry. So I welcome both of you. Thanks, Dr. Aves, for joining this session. I know it's early morning for you in USA. Thank you very much. And I hand it over to Soumitra.
Thanks, Kaustubh. Thank you for the introductions, and thanks for asking us to do this session. For those attending, this is really a pleasure for me to be having a chat with Aves. Aves is what Kaustubh did not say, probably because he was doing a very formal introduction, is Aves is probably one of the most exciting talents in the field of psychiatry, and especially in the field of looking at psychiatric ethics per se, and also the philosophy of psychiatry. I discovered Aves on Twitter, of all the places, and we've been chatting for a while on Twitter. So always welcome, and thank you for doing this. Thank you so much.
Yeah, no, thank you so much. It's a really honor for me to be here. Thank you, Costa, for the introduction, and Soumitra. I've been a fan of your work for a while now, so I'm really excited that we get the opportunity to talk and discuss.
Yeah, so let's get on with it. I mean, this is always for you as well as for all the listeners. This is just going to be a conversation, okay? So this is not about doing a kind of, we're going to be much more informal and laid back, and we leave some time for questions, but actually try and tackle some really important issues. So to begin with, Aves, can I get you to just start by saying a little bit about yourself, your background, your personal background, all of that stuff? If you can just give people the idea of you as a person.
Yeah, certainly. So I guess a very important thing is that I actually I'm from Pakistan. That's where I was born, where I grew up. That's where I did medical school. And then after medical school, I was briefly in Doha, Qatar for about a year. I started psychiatry training there. while I was waiting for my US stuff to work out. And then afterwards, I matched in the US. I completed my psychiatry residency and fellowship, and I work in the US now as a psychiatrist. So, but for that reason, I kind of like have this sort of like, international perspective on sort of like psychiatric and medical perspective, especially kind of growing up in Pakistan and seeing attitudes towards mental illness and the state of psychiatry, sort of like, the stigma that surrounds sort of like, the patients, as well as, people who work with them. And then, working briefly in Doha, Qatar, very different sort of culture than the South Asian one, very different sort of social dynamics, different sorts of cultural presentations. And then sort of like being in the US, again, a very different culture, different dynamics of healthcare presentations, were very different. So I think that cross-cultural perspective, I think, really emphasizes the degree to which I think presentations in psychiatry are influenced by culture, sort of like, the way symptoms are expressed, the way the expectations that patients have from their providers, and also the difficulties that sort of like, people face in different cultures. So I think that really, I got an appreciation of that through my direct experience. The second thing is that I was really interested in philosophy from the very beginning. Even before I started med school, I really wanted to be a professional philosopher. But in Pakistan, I'm sure it's similar in India as well, that sort of like would have been like financial suicide in a certain way, sort of like, not a lot of viable path there. And so it just so happened that I ended up in med school, and I realized pretty quickly that psychiatry was the only specialty that really sort of like, fit my interest and appealed to me. And that was that was kind of challenging, because especially like in my family, the perception around psychiatry was kind of somewhat stigmatized. The general sort of idea was that, oh, if you're a good medical student, you're getting good marks, you're and sort of like, you're bright, then you go for like medicine, surgery, or some of the other fields. You don't really go for psychiatry. So I had to face a lot of resistance from my family, my colleagues, teachers. But eventually I decided that, if people like me don't go into the field out of the stigma, then how will we change things? And I kept up with my philosophical interest as well. And I discovered that there's this rich, thriving discipline of philosophy of psychiatry. So as I progressed through my training and my career, I became more and more directly involved. And I've been very lucky that I've been a part of the philosophy of psychiatry community in sort of like, at least in the US and Canada, to a little bit in the UK, but for several years now. And I've had an opportunity to be an active participant in these issues and to contribute to these things. But for that reason, I've had an interest in philosophical and sort of like, critical aspects of psychiatry, because psychiatry as a profession is mired in so many controversies. Mm-hmm. So some of the work that I've been doing in the last couple of years has been focused on exploring these issues and making these issues more accessible to a wider audience.
Yeah, I was the bit that I completely related to two bits really. One was this thing about your family being against you taking up psychiatry. I mean, I can relate to it completely. When I took up psychiatry, and that's a long time ago. I'm now quite old. This is 30 years ago. And my father said, for once in your life, can't you just do something normal? Why, why would you want to do something different? And my mother basically said on the phone to someone that he's doing his post-graduation. And, I don't keep track of what subject he's doing and all such things, knowing fully well what I was exactly doing. So, I can completely understand even the stigma within families of people who take up psychiatry to kind of not want to talk about it. And you mentioned culture, and I'm just curious to know, with your experience in the US, because I've never worked in the US. I worked in the UK for a while. And one of the things I remember saying then to one of my consultants was, I said, what, eating disorders are a cultural syndrome, a culture-bound syndrome, except our textbooks never call them a culture-bound syndrome. Because my experience was that you rarely saw them in countries like India or Africa, in places in Africa, whereas you saw a lot of it in the West. And I don't know, I'm just curious, what do you feel about all of these, which are classically called culture-bound? Psychiatric textbooks are full of culture-bound syndromes. They all happen to be only happening in Asia and Africa, and nothing ever happens in the West.
Yeah, no, I think that the idea of culture-bound syndrome, I think especially the way it originated was, I think, influenced by a lot of colonial and racist kind of like mentality. It was sort of like this idea that we in the West, we are the normal, we are the sort of like, the reference group, and any other sort of like culture that departs from it, they are the unusual ones, and it is their syndromes that have to be characterized as being culture bound. So I think the most of the work that was done in the 20th century on this issue was heavily colored by this sort of like racist, colonial, oriental kind of biases. I think in the last 2 decades, thinking has shifted. I think as awareness have grown and people have started realizing that there's nothing privileged about sort of like psychiatric presentations in the West, and that the West is sort of like as susceptible to their own I think culture bound syndrome. I think this became really prominent, for example, in the 90s with the multiple personality disorder epidemic that happened in the US. I mean, sort of like we have this one country where there are so many cases of multiple personality happening, and the rest of the world nothing. And I think that kind of highlighted how even sort of like things like that occur. I would definitely, I would say, I mean, I think there are certain syndromes, I think, that are more specific to a particular culture. But I think even for like syndromes that are more general, you see a lot of variation in prevalence. So for example, in Pakistan, we used to see a lot more somatization. Sort of like, it was like extremely, extremely common. Sort of like, people would present, a lot of them would present with various sorts of kind of like, vague somatic complaints that are sort of like, that if you took a detailed history, you could tell is being driven by psychological factors. But the tendency was that if you're depressed, if you're anxious, you're predominantly going to present with sort of like, an array of somatic symptoms. Then another thing was that conversion disorders were really common in Pakistan, especially in women. And I think that was a function of, I think, of the continued social oppression. I think sort of like, it's one of the ways in which I think, I think the social oppression registers on the individual psyche. When I was in Qatar for a year, it was really striking to me that how many acute reactive psychosis I saw. Psychosis in general is it's a somewhat rare condition, but I think in Qatar they have this unique social hierarchy where they have sort of like really poor laborers from South Asian countries, Nepal, India, Bangladesh, Pakistan, working in extremely difficult conditions, and they are trapped there due to a variety of legal and financial reasons. And then sort of like, in that working in those extremely stressful situations, many of them sort of like starts experiencing acute psychosis, and they would then sort of like, get admitted to the psychiatric unit, sort of like, get stabilized. And the presentation was like very different from the sort of chronic schizophrenia that you see in other countries. So that again was sort of like so remarkable to me, because once I moved to US, I saw a lot more schizophrenia, but sort of like, that sort of acute transient psychosis was, fairly uncommon, which again, I think sort of like, emphasizes the link between psychiatry and the sort of social cultural conditions, and also the ways in which psychiatric conditions can be markers of social distress and social oppression.
Yeah, that you raise a lot of questions around diagnosis, and so I was going to actually kind of get into that. This notion of psychiatric diagnosis and classification, and what you just said, so much of it is colored by what happens, and unfortunately, psychiatric practice and especially medical psychiatric practice, it tends to reify diagnosis as being some kind of a absolute truth. And so I just wondered what you feel about all of these diagnosis controversies, the new DSM-5, and with the controversies around that. Just wanted to get your take on that.
Yeah. I think the sort of like, the controversies around diagnosis are, I think marked by two sorts of polarities. I think the classic sort of like tendency is to view psychiatric diagnosis as sort of like, as representing pathological entities in the same way we think of, for example, sort of like, the type 1 diabetes mellitus, or the same way we think of, let's say, adenocarcinoma, right? So sort of like, we're thinking of like specific sort of like medical entities that are characterized by something as an essence, a pathological process as an essence. And the technical, the philosophical term for that is called natural kinds, that you have sort of like, that you have identified a category that matches with a category out there in the nature. And the classic example of natural kind is the periodic table of elements in chemistry, sort of like, that it's a classification, it's a category, these are categories that match sort of like, the actual atomic structure of the molecules. On the other hand, sort of like, the other sort of position is sort of like this idea of social construction. And it's this sort of idea that, oh, these are just sort of like, these are just like arbitrary labels that we are imposing on sort of like, people, that there's no connection to sort of like, to the neurobiological, neurophysiological reality at all. It's just sort of like, it's just it's the entire thing is socially constructed, sort of like, it's a social process. The way we have constructed money, the way we have constructed sort of like, political borders, in the same way we have constructed sort of like these diagnoses with no relationship to any sort of objective reality. And I think the challenge, I think, in the sort of like in the critical community is that we see this sort of like polarization, that they challenge this sort of like, this biomedical view of diagnosis as representing disease entities. But then sort of like, in their challenge, the alternative they present is that, oh, it's just all social, it's all made up, it's all arbitrary, these are just like, social labels. And I think what we have seen in philosophy of psychiatry in the last 3 decades is that philosophers have tried to figure out the sort of like, a way to integrate them and sort of like, find and navigate sort of like path. And the idea that has become quite common is what is called pragmatic kinds, or sort of like practical kinds. And it is the idea that we are sort of like dealing with a complex dimensional reality. Sort of like, there are many sorts of mechanisms and processes. There is no categorical demarcations in these processes. It's not like a mechanism ends somewhere and sort of like, let's say a normal depression ends at one point and major depression ends at another point. There's no demarcation in nature. But there are mechanisms out there that regulate mood, that regulate emotions, sort of like, people present with a variety of symptoms. And then, so there's this sort of like this dimensional landscape of various sorts of neurobiological, psychological processes. And we sort of like, impose categories on them based on our pragmatic goals. Sort of like, if we want to, based on our scientific interests and clinical interests, we want to identify people who are presenting with a certain sort of like, certain threshold of disability. We want to identify people who respond to a certain treatment, or we want to identify people whose presentations, or we want to sort of like, identify genes related to a certain presentation. So we can create what are called practical or pragmatic categories that guide our scientific and clinical work. But it's not as if that they are made up, or they sort of like, they have no sort of like, justification. It's just that sort of like, the nature of those categories is different. And so I think that's what I feel, is that I think if we begin to see these categories for what we are, that these are models, they are tools for us to use. And the challenge is that we should not attribute to them a reality that they do not possess. But at the same time, we should not sort of like dismiss them as just being arbitrary and completely made up.
Yeah, I mean, this is an important point that you make, but it is so difficult even for psychiatrists, especially, I find, and generally mental health professionals, to get their head around. What you just said, this kind of understanding it along the spectrum and being able to keep that without reifying diagnosis onto some pedestal. My question to you would be, how do you get this across to the average Joe public? And I'll tell you why. Because sometimes when you're talking to people who have, say, a bipolar disorder or a schizophrenia for many years, and when you talk about these issues, or when you talk about the fact that, look, these are social constructs at some level, it is perceived as you are denying my suffering. You're denying the fact that I've actually lived with this for so many years, and I know I experience it. Now, how do you get that across to the average person who has lived experience, that what you're just saying is not a denial of their lived experience, but is actually trying to make sense of it in a slightly different manner?
Yeah, I think we have to. I think the thing that I find the most helpful is that introducing this idea of plurality of perspective, that if we have a complex, multifaceted phenomena, there's no one single right way to look at it. For example, like Peter Zakar, he sort of like, he gives the example of like carving a turkey, sort of like, there's no sort of like one single correct way of carving up a turkey. You could sort of like, do it in many different ways. And depending on what we want to do with it, sort of like, some ways are going to be better than others, but there's no one single correct way of carving a turkey, or sort of like, or there's no one single correct way of organizing a library. Sort of like, you could sort of like do it in many different ways. There are good reasons for doing them in different ways, but so it's not like a made up process, but you could do it in multiple ways. And I think sort of like what I try to do, communicate to patients is that, your suffering is very real. Your sort of like, your experiences are very real. What you're experiencing. It's just that sort of like, we have multiple ways of describing what you're going through. It's such a complex process, and the language we have at our disposal is so limited that there is no one single objectively correct way of saying this is it. You could describe it in a certain way, and that way has advantages and disadvantages, both clinically and scientifically. But that also sort of like that doesn't mean that there are not other ways you can describe the same presentation and the same kind of thing. So I think when you introduce sort of like complexity, multifacetedness, and the idea that complex phenomena can be looked at from different angles, I think that seems to help. I think if you want to use like a more scientific analogy, for example, in quantum physics, sort of like we now talk about the wave particle duality, right? Sort of like, it's this complex quantum phenomena that sometimes looks like a particle, that sometimes looks like a wave, right? So you can, it's helpful for us to sometimes describe it as a particle and sometimes describe it as a wave, but the reality is much more complex. So I think, we have to sort of like see these diagnoses as tools that we are using that are helpful for the ends we are trying to accomplish.
Yeah, I mean, this makes sense at some level, I suspect, to professionals. And one of the things I frequently come across, patients who will say they've seen like 5 psychiatrists, and over a period of time, they've got a diagnosis of bipolar disorder, then a diagnosis of schizophrenia, then somebody gave them a diagnosis of personality disorder, and they're totally confused. They'll say, I saw 5 different psychiatrists over 6 different years, and I've got 7 diagnoses to show off. So what exactly have I got? And it's difficult, isn't it? Because what you're trying to get across to them is that while you might have all of those 7 diagnoses, and they might be completely compatible because these things are amorphous in that sense and might change over time. But because diagnosis is then seen as a diagnosis in the way physical diagnosis is, as very categorical and discrete from other diagnostic categories, I think our patients actually struggle with these kind of things,
Yeah, they do. And I think it's difficult. I think one of the reasons is that I think we have emphasized diagnosis a bit too much, I think, in how we organize our clinical work and what we communicate to the patients. I think diagnoses are, they have value, but they're often not the most important thing about a clinical presentation, or they're not the most important thing that needs to be communicated to the patient. And I think another thing is that the diagnosis kind of obscures the relationship between the symptoms and the context and the past psychological history. Sort of like, it sort of like, it just gives them a label, a category, but it doesn't sort of like tell them how their symptoms are related to the rest of their life and to the psychological life. And what the people often call the idiographic perspective is sort of like, how do your particular life story, how do your particular trajectory of symptoms sort of like, make sense, which is, what is the idea of the psychoanalytic or psychological case story. So I think it's partly our fault as well, is that we have put the diagnosis on a pedestal, in our clinical work and in our communication with the public, when in fact we should be emphasizing the richness of the ways sort of like, in which psychiatric problems emerge and psychiatric problems patients experience them. We should be emphasizing the phenomenology. We should be emphasizing the relational aspects. We should be emphasizing the socio-political aspects. I think we have impoverished our own profession by focusing so much on diagnosis alone.
Right. I mean, from a philosophical as well as from a from an ethical perspective, why do you think psychiatry has got this obsession with diagnosis? I mean, is that something to do with our own, handicaps or shortcomings about not feeling completely part of medicine and medical profession, and this is like overcompensation in some sort of way.
Yeah, I think there's definitely an element of that. I think sort of like it's a sort of like aspiration that we want to be objective in the same way as sort of like, oncology is, or sort of like, internal medicine is. And so I think we have a certain ideal of medicine in mind, and we try to sort of like, fit psychiatry into that. And I think the sort of like, the general public has that sort of thing too. But even though I think, the medical perspective is really helpful, I think that sort of blunt categorization is just not sort of like, very ideal for our profession. I think psychiatry has to recognize that it's much more richer, it's much more complex than what's going on in medicine. I think, instead of sort of like, us being envious of medicine, I think we should celebrate sort of like, psychiatry for its own sake, and sort of like, I think psychiatry presents the sort of scientific and sort of like, philosophical challenges that I think the rest of the medicine often doesn't.
Yeah, absolutely. I mean, one of the reasons I got into psychiatry was exactly that. It sounded interesting and fascinating, rather than the boring bits about just that you did in medicine and surgery. So
yeah,
and somehow clinical psychiatry, when you're learning to practice, just seems to lose all of that. Well, I was you recently wrote a blog, and I wanted to turn to that. This is about the whole issue and controversy that has gone on around antidepressants, and whether antidepressants actually work or don't work. And this is just something that has been, it's not been so prominent maybe in low and middle income countries, and I don't know why that is, but it is I know that it is a conversation which is quite prominent, especially in the West and in high income countries, around whether and the whole issue of how critical psychiatry views that. So I was just curious to know of your take on that. What do you feel about it? Especially because I have read your blog, so maybe you could start from that and try to summarize some of what your ideas.
Yeah. I think sort of like, I think there are kind of particular historical reasons why this controversy has kind of like, I think it's much more in the West. I think I think, as we all know, there was this sort of like this whole chemical imbalance narrative that was promoted by kind of like, the anti-stigma campaigns and pharmaceutical companies in the 90s and 2000s. And I think from their perspective, it was a sort of way of emphasizing that these are real medical conditions. But I think they kind of like overdid it. And I think from the pharma side, there was this idea of like, using that idea to sell more antidepressants. But I think the popular perception in the general public became that, sort of like, depression is caused by low levels of serotonin, and antidepressants increase serotonin, and that's how they work. So I mean, even in the 90s, the scientists knew that story didn't hold up. I mean, they knew that the studies didn't support that things were like much more complicated. There were sort of like, studies showing that serotonin is involved in some kind of complicated way. There might even be like some abnormalities, but the whole picture is very complicated. It was like across multiple levels. The idea of a simple serotonin imbalance that is being corrected by SSRIs was just like not true. But the public kind of believed that. And for that reason, I think many physicians kind of continue to emphasize that too. That kind of like became one of the main issues that some of the critical groups in the West, especially in the UK and US, took up. And they started saying that sort of like, this is what mainstream psychiatry says. And so there was like a continuous sort of like, wave after wave of sort of like, assaults on sort of like, on depression and sort of like on antidepressants, by sort of like saying that, sort of like, that story is incorrect and false. And I think the most recent version of that, I think they really sort of like, came out with all like guns blazing, is that sort of like that was this umbrella analysis in molecular psychiatry, sort of like showing that if you sort of like looked at all of the studies, that there wasn't any convincing evidence that there was a serotonin abnormality or low levels of serotonin involved in depression. That was the paper. It came out, I think, in July. The issue is that sort of like, the critical psychiatrists started using that finding, which scientifically itself is fairly uncontroversial at this point, they started using that to saying, one, that like depression has no biology, that depression is just like it's just like a normal response to your life circumstances. There's nothing but the sort of like abnormal or nothing dysfunctional about it. So one, sort of like they started pushing that narrative. And the second thing, they said that if there is no serotonin imbalance, then there's no reason why antidepressants should work, and there's no reason why they should be effective. And they sort of like they started using that as a way of like challenging the efficacy of antidepressants too. And it became quite sort of like it became a sort of like a sensational story. Like all of the major newspapers kind of highlighted that. Unfortunately, they also gave too much credence to these sorts of social constructionist views about depression and sort of like the lack of efficacy of antidepressants. So I was sort of like I have a critical view as well. I don't think depression is just like a simple brain disorder or brain disease. I'm very critical of that narrative. But I think at the same time, we can't simply deny that there is a neurobiological dimension to depression, or the fact that sort of like that these experiences are embodied, and there are brain mechanisms involved. And also, I mean, millions of people across the world take these medications, and they sort of like many of them find them quite effective. They don't work for everyone. Many people sort of like don't find them effective. Many people have a serious adverse effects. All of that is true, but there's a big chunk of the population that finds tremendous relief, which is also borne out by many clinical studies. So my sort of like emphasis was to try to like bring a little bit of like nuance to this debate, and instead of like swinging in between the antidepressants are really effective, they really work well, and they don't really work at all, they're just like placebo pills, to try to show like here's what the evidence shows. And evidence shows is that the situation is kind of mixed. They work to an extent, they work for a subgroup of people, they have reasonable efficacy. We are probably overprescribing them, especially in the West, but we need to be taking sort of like again sort of like a more realistic look at the neurobiology of depression and the use of medication, rather than swinging in these sort of like polar positions. And I think it's sort of this dynamic between pathologization and sort of like dismissal of the reality of illness. I think if you call depression a brain disease, then you're sort of like you're reducing that rich psychological experience to just like the brain, something wrong with the brain. Versus if you say that depression isn't even a disorder, medication, there's no need for medications, you're denying the reality of the distress, disability, and the impairment, and the role that medications bring. And so I think it's just a very unhelpful dynamic, and we really need to sort of like get our stuff together and sort of like look at the actual science, which is which appreciates the complexity of this.
But what do you? I mean, I'm curious. What do you think is the political context to all this? It seems to me that one side, as you said, would focus on the biology to kind of almost deny the existence of any kind of social or psychological issues which might be at work. And then the other side would like to deny biology completely and make it a purely social construct. And there is also a third side, which has been very quiet at the moment, which is the ones who will make it a purely psychological construct. I suppose they've had their heyday before. And I wonder, what's the political context to these behaviors that is going on? This is not the first time we are being through this. This is something we've had over many centuries now. So I'm just curious, how do you see it from a political perspective?
Yeah, the politics of this is like really kind of interesting and kind of complicated. The issue is that many of the leading critical psychiatrists who are making these sorts of claims, they are kind of working in a more sort of like socialist Marxist kind of view. They're saying that they think that these basically depression basically is just a form of societal oppression, and just there's nothing more to it. It's just basically the society is so terrible that people are getting depressed. So the solution for that is that we need to bring about socialism. We need to like abolish capitalism and all of the exploitation, and let's bring about a socialist system kind of thing. That's what is motivating a lot of the critics. The interesting thing is that their work is actually being received with enthusiasm by the right-wing politicians in the UK and US. And their interest is that they want to say that, mental illness is just like normal suffering. And if it's just normal suffering, we don't need to invest in mental health care. We don't need funding. We don't need to sort of like, so they use that as an excuse to cut funding for mental health services. So it's sort of like it's having a very sort of like paradoxical effect. And then in the US, especially sort of like, these sorts of ideas are being picked up by the conspiracy theorists and by the far right commentators. So for example, like Tucker Carlson on Fox News, he started saying that that mass shootings in America are happening because of antidepressants. So some of the right-wing conspiracy elements are using these ideas for their own ends. So the politics of this is like really, really kind of paradoxical that, the critics are motivated by this sort of Marxist ideas about reforming society, but the actual people who are listening to them are these far right people and conspiracy theorists.
It's just fascinating, isn't it? I mean, this is just one of those very interesting, and I tied up with a lot of loss of faith in institutions and loss of faith in the existing political process. I mean, that's where all the conspiracy theories and all come in, and now mental health and psychiatry getting itself into that space. In the same way that vaccines have got caught up into that space, vaccines have got caught up into a contemporary political conversation in which it's polarized between people with conspiracy theories and all of that stuff. So it's interesting that psychiatry has also got itself into that space.
Right. Yeah. And I think,
so to
it also
speak,
highlights, and I think from like how, like, I think the dynamic is very different in South Asia, for example, because we don't have the same sort of over medicalization problem in general. And in fact, we have so few psychiatrists and sort of like, we have such little access to medical services that the challenges are sort of like, very different. Now, there are pockets of the population who are subject to that sort of over medication, where medications and overdiagnosis is a problem. But for the average person in South Asia, they don't get a diagnosis and they don't get medication. They're lucky if they get anything at all. I remember when I was a medical student, I went to my father's ancestral village, and sort of like in one of the homes, a person with psychosis was chained to the tree, and sort of like, and it was just like really kind of like, really shocking to like see directly, because I mean, and that they were kind of forced to do that because they had access to nothing medical there at all in that remote village. So like, the only way they were trying to control the disruption of the psychosis was by, these sorts of means. So I think people in the West don't realize that. I think they fall prey to the romanticization of mental illness. They don't have the living memory experience of what pre-modern mental illness sort of like, looked like. So and so I think people, because of that, on the ground situation, this sort of like, combined uneven development, the people I talk to from South Asia, they kind of like, view this whole critical psychiatry controversy with kind of like what's really going on here, like, because it doesn't fit their context. It doesn't sort of like reflect the global needs of mental health that people are sort of like facing right now.
Yeah. Well, before we move to another topic, I know that we are also running out of time, so I just wanted to kind of just remind our listeners that if any of you had a question for Awais, please put it in the questions box. We have, I'm going to ask him one or two more questions, and then take your questions. If you had anything that you wanted to ask, please put them in right away. While we wait to hear questions from people, I also wanted to get your view on from a philosophical perspective around this whole debate again, which has been happening and around the issue of involuntary treatment and global mental health, and what is happening in both Asia, Africa, and also in the West.
Yeah, I mean, I think it's a very complicated, I think, ethical and political debate. And I think again, sort of like, I think we see some pretty kind of like strong views on the matter. I think there are, from like people, I think who firmly believe that I think there needs to be more sort of like, involuntary commitment. They think that, if the person lacks insight, then it is the responsibility of the state to step in and the medical profession to step in and help them. And then there are sort of like people who have had like really terrible experiences with involuntary psychiatric care, and they recognize like, how traumatic it is. And they take the view that we just need to abolish this entirely. Then there needs to be like, there should be no involuntary treatment at all in psychiatry. And this, I think this debate has been kind of like energized by the UN stance on this, or like, which they took in CRPD, Convention of the Rights of Disabilities, is basically they said that UN basically said that they don't think that involuntary treatment is justified in any way for people with disabilities. And so that generated a huge debate, and I know you have been a part of that too. There was the volume by Cambridge University Press that that came out, really excellent discussion in that. And I think my own views have, I think, kind of shifted on that over the years. And I think I see, one is sort of like this sort of like abstract idea, like, can we abolish involuntary commitment like entirely, sort of like this ideal, like, can we do it, in under ideal circumstances? And my suspicion is there's probably going to be need for like some involuntary commitment even in ideal circumstances because of the nature of psychosis. But but we are so far away from ideal circumstances that the debate doesn't really make much sense. It doesn't make sense to debate in theory, could we do it? We have to look at sort of like what's happening on the ground. And I think it is true that the degree of coercion that we are seeing right now, it can be much less than it is right now. And what needs to happen for that is there needs to be like tremendous community support for individuals with serious mental illness, which sort of like which means investing in sort of like forms of outpatient care, which means investing in clubhouses, forms of employment and socialization. We have to sort of like have less restrictive ways of treatment, like sort of like crisis stabilization units, and so including like non-medical crisis houses, things like that. So I think if we invest really heavily in the community, we will be able to bring down involuntary commitment and involuntary coercion dramatically. And I think the best example of that comes from Trieste, Italy, is that in the 80s, 90s, sort of like they also shut down their asylums like a lot of the rest of the world, but they invested very heavily in the community. They developed one of the world's best mental health systems, and resultantly sort of like the rates of involuntary psychiatric care in Trieste, Italy are exceedingly low, sort of like impressively low. Versus in the US also shut down the asylums, but they didn't invest in community mental health care. So the end result became that all of the people who were in the asylums with serious mental illness, they ended up becoming homeless, and now most of them are in the prisons. Sort of like right now, the prison system in the US is the largest psychiatric facility in the US. There are more people in jail right now than there are in hospitals. And I think that speaks to the sort of like, I think that, again, the reality of mental illness. It's not like we can close our eyes and it'll go away. There are people who need our help and support. And if we can't provide them in sort of like, in the forms of asylum, then sort of like, we see this sort of like where the legal system takes over. And the solution to escape that is, I think, investing really heavily in the community, developing forms of support in the community. And I think if we do that, I think that's the real productive direction. I think instead of debating, can we eliminate psychiatric coercion entirely in theory, which we might be able to do in 100 years, who knows? But it's like so far away. What we need to be doing right now is investing really heavily in the community, so that we start moving in that direction, even if that's a goal that we can't really accomplish.
Yeah, my personal view is that this is the Overton window in operation. This is the reality is the CRPD and the UN have effectively at least put a reduction of coercion or at least eliminating coercion back on the agenda because of this. And it's an attempt to shift the Overton window, so you're towards the center in a sense. And I think that's really what is happening at the moment. I don't know, would you kind of see it that way?
Yeah, I agree. I think, I think the sense I get is that I think they really, I think, wanted to shift the debate in that direction, and they realized that advancing softer positions is not going to be very effective. People are just going to ignore them. I think the only way to actually force the systems and force the profession to tackle this was by presenting this sort of like provocative kind of claim out there, which, and from a very prestigious institution, which forced the governments and sort of like, the profession to look at it. So that's my sense as well. I think the UN, I think it's presenting an aspirational goal, sort of like, and because of it, by presenting it as such, I think it's forcing us to try to move towards it. So I agree with
and
your
also,
assessment.
also the whole, I also think psychiatrists have been very anti the whole idea of reducing coercion or any of that sort. And I think it's a combination of things. Psychiatry with its own anxieties about where it is placed in medicine, and its own uncertainties about existence within, or its own dynamics about its own existence in medicine, combined with the fact that involuntary treatment actually brings power to psychiatry, which is quite huge over people. So you have a profession which has its own anxieties and uncertainties, and on the other hand, it has this huge power. And you can almost begin to imagine why they would not want to kind of let go of all of that so quickly, and of course, it'll always be cloaked as well. It'll harm people, and it's not for ourselves, it's for people. But you see, if it was for people, then the argument should have been we need more community services, as you said. We should be saying, yes, we want to eliminate coercion, and the only way to do this would be if we can get more community services. But that's not the argument you hear.
Yeah, you're right. I think there's a lot of sort of like insecurity, and I think, and there's defensiveness, and there's also sort of like the power dynamics where sort of like, I think psychiatrists want to hold on to that power. I think what happens is that I think when this debate happens, when people say that, oh, we should be reducing coercion, or we shouldn't be having we should this is not something we should be, promoting. I think psychiatrists feel as if we are individually blaming them. We are saying them like, you are doing something wrong, sort of like, so they take it kind of like personally and individually, and I think, my thinking is that it's not about the psychiatric profession. This is a question for societies. It's not up to psychiatry, sort of like, what's going to happen with this issue. And I think it's really, I think it's a matter for societies to determine how to best tackle that, because the psychiatric profession sort of like can't solve the problem sort of like on their own anyway. I think they're caught in that sort of like their own dynamic. So I think, and this is also something I think the UN highlights, is that the UN is not talking to psychiatry. UN is not saying to psychiatry, it's talking to member states. It's saying to the governments, you need to get your act together and do this, because again, the resources that are required to accomplish this is something that can only happen collectively. And so I think from psychiatrist's side, we need to be, I think, facilitating this process. We need to be encouraging it. We need to be saying, yes, yes, that's great. Let's have more services for the community. Let's have better, more humane care. Let's have sort of like, more care with respect and dignity, right? So we should be collaborators in this process, but unfortunately, due to sort of like this defensiveness and due to taking this as a personal attack on ourselves, we have sort of like, I think, become suspicious of this, which is really unfortunate.
Oh, we have a question, Awais, so I'm going to read this out for you. It says, this is from Georgia Fernandez. It says, Dr. Aftab spoke about this chemical imbalance narrative around serotonin. There are a few psychiatrists in India who still give this serotonin theory as an explanation after diagnosis, and it is not a thing of the past. Does the theory not hold true now? What are patients supposed to believe is the right treatment for their mental health condition, especially when doctors rely only on antidepressants for treatment?
Okay, yeah. So it's from a scientific perspective, it's kind of it's a complicated answer. I think what research seems to suggest right now is that the serotonergic pathways, as well as the other sort of like, norepinephrine, dopaminergic pathways, these pathways are involved in the general regulation of mood and emotions. So they are involved in sort of like in the expression of depressed mood and sort of like a lot of the other symptoms of depression. But there's nothing like technically wrong with them. It's not like there's like high levels of serotonin and low levels of serotonin categorically between depressed, non-depressed. It's just that that's a pathway through which depression is expressed. And because that pathway exists, we can act on it. We can sort of like tweak it, and we can see improvement in symptoms. And I think a good example of that is, let's say you're experiencing fever. You have an infection in the body. You're having fever. Now the fever is being generated through like prostaglandin pathways, sort of like in the brain and everything, right? And you take an anti-fever medication. Let's say you take ibuprofen or aspirin or whatever. It acts on that pathway, sort of like it sort of like blocks that transmission or modifies it, and sort of like the symptom is reduced. But it's not like that pathway itself was abnormal. There was nothing wrong with the prostaglandins. I mean, they were doing just what they're supposed to do, but the pathway was there. You could act on it. And I think the similar sort of thing is that there are these certain monoaminergic and serotonergic pathways in the brain. There's nothing wrong with them, but they are involved, and you can act on them. In the same way, let's say if someone has sort of like someone has edema, and sort of like let's say edema due to heart failure, you can give them diuretics and relieve the edema. I mean, there's nothing wrong with the kidneys, right? But you can but because they're involved, you can give them diuretics and sort of like act them. So I think we have to think about how the medications are working in that sort of thing. And we know now that there are downstream effects, that when we act on these pathways, there are downstream effects on neuroplasticity and neurogenesis. Sort of like the general kind of idea is that the brain circuits kind of become a little bit more flexible, so that they are more receptive to environmental stimuli. And if you get the right sort of environmental stimuli, you can sort of like the brain can recondition itself. That's one of the working hypotheses right now. So I think but that still emphasizes, that still shows that depression is this like complex process which which exists across biological, psychological, and social dimensions. So like my advice is that we should sort of like start moving away from this sort of brain disorder, chemical imbalance sort of explanation. And we should be telling patients that this is a complex phenomena that involves both biology and sort of like psychology and social factors. And that, because there are pathways in the brain, we can give you medications to help with that, but they're not going to be enough by themselves. And we sort of like, we also need psychotherapy, and we also sort of like, and different people have different needs. Some people are going to respond well to medication. Some people are going to respond well to psychotherapy or other forms of intervention. So we need to like kind of like personalize sort of like care as well. So I think we need to recognize complexity, that there are sort of like, it's a complex process, multi-level. Two is that things don't need to be abnormal for us to intervene on them through medications. And number three, heterogeneity. Different people have different needs, and medication is not the solution for everyone.
Oh, thank you. We don't have any more questions at the moment, Awais, and I know it's 3 minutes past 7, and I know we started a little late. So I'm since there are no more questions, if something comes up, I'll ask you quickly. But otherwise, would you like to make some kind of, closing synthesis of what is happening, and where do you see us going? Where do you see the interesting questions might lie, and where do you see the profession going from here with all of these controversies that do exist?
Yeah, I think I'll kind of reiterate. I think the path forward from my perspective, both philosophically and scientifically, is that how do we break free of this polarization that we are seeing between this sort of like neurobiological reductionism and this sort of social constructionism? Like how do we break free of that? And I think what we need right now is I think there's a lot of good work in philosophy and sort of like psychiatry that is trying to do just that. I think the psychiatrist Kenneth Kendler has done really good work. There's Peter Zacher, who's a psychologist, and I have been trying to explain these ideas in my online writing as well. I put the link to my blog in the chat as well. So I think the path forward is what we might call it. So there's this psychiatrist in South Africa, Dan Stein. And he calls it the classic and the critical perspective. That's sort of like this classic neurobiological view and the critical social kind of view. And we really need to integrate that. We need to take the integrative position where we take the best of both worlds. And I think that's where we need to direct our energies on, is that these sorts of polarized positions are not going to help us. They don't help the patients. They don't help the professions, and so sort of like that. And the thing is that, I think speaking on the second point about involuntary care, I think we have to look at the power imbalances. And I think, instead of psychiatrists unilaterally making decisions about what's good for the patients, we need to be it needs to be a lot more collaborative, both at the individual level as well as at the social and the political level. Is that we need to be engaging with the patients. We need to be sort of like seeing what are their priorities, not what we think their priorities are, but what are their real actual priorities in their lives, and sort of like, what are the things that they want to accomplish. And sometimes symptom reduction is important to them, but sometimes other things are important to them. Symptoms are kind of like the peripheral. So I think the other one is that we need to move towards this sort of like pragmatic integrative positions, and the other thing is that we need to move towards more collaborative, democratic kind of like interaction with our patients and with psychiatric patients generally in the society.
On that note, I think that's a very positive way of looking and going forward. I think on that note, I'm going to thank you for this long discussion. I think we've been at it for an hour. It's gone by very quickly, and look forward to reading more about your blogs and your articles as you keep on posting them. Thank you so much for making the time. I know this is very early in the morning for you, but thank you for making the time and joining us today. I'm going to now hand it all back to the organizers, or if Kaustubh is around, maybe just to Kaustubh.
Yeah,
I'm there.
Okay, Kaustubh. Thank you so much, Kaustubh. I'm going to hand it back to you, and you can take it from here.
Thank you. I had a great time, sort of like, and I think this is a great conference. So I want to congratulate the organizers for organizing something so great.
Thanks, Awais. Thank you.
Thanks, Awais. Thanks, Soumitra. Both of you, really thank you for this really great discussion around these difficult topics and navigating between, as you said, Awais, between these dichotomies and polarization. For all the participants, this is the last session for the day. We are going to now end the day. Before that, I want to hand it over to my colleague Arjun, who is going to wrap up the day with some remarks and vote of thanks. Thank you all. Over to you, Arjun.
Thank you, Kaustubh, and thank you, Soumitra and Awais. I think that was, I'm still processing that incredible conversation. Of course, been following these debates, but it's been really great listening to this. Also has put a lot of things into perspective. So thank you for that. I think we've had a really amazing afternoon and evening of some incredible speakers who've come in and shared a range of perspectives. Our theme was changing mental health paradigms, and the idea was really to really look at some of the key paradigms that sort of operate within the mental health and suicide prevention space, and how do we sort of understand these paradigms? What is it that we need to change? What do we need to question? What are the assumptions that we need to sort of really relook at? And how do we sort of look at the future when it comes to mental health and suicide prevention? I don't want to take too much time because we will be publishing the proceedings of this conference. Eventually, we're also going to be putting up recordings of each session, so the audience and others can always access it. Just in terms of 2 or 3 key insights which have sort of emerged from the discussions during the afternoon and the evening has been, of course, relooking the whole idea of definitions, starting from the definition of mental health itself, and this is something that Dr. Rochelle sort of spoke about in the keynote address. Is how do we start relooking? How do we reimagine the idea of mental health and move away from binaries? Whether it's mental health and mental illness. How do we begin to look at mental health from a far more complex and nuanced perspective? And this is something that even Awais and Soumitra's conversation sort of touches upon the plurality of approaches and kind of looking at things from a more pragmatic perspective. I think the other important insight that sort of has emerged is really to also kind of look at both ends, the individual, and it's something that Awais said, which is to personalize mental health care, but at the same time, something that the other speakers in the other sessions have also pointed out is to also look at the systemic aspects of mental health and look at the political economy within which our discourse and just mental health as a phenomenon is experienced. So how do we look at issues around race, gender, sexuality, caste-based discrimination, and how do we also move the discourse from just about mental health and poverty, but to look at far more complex realities and social determinants, including things like climate change, the impact of the pandemic. We're also talking about violence against different communities and groups, and of course, the rising rates of suicide, especially in low middle income countries. The other important insight, which sort of has, of course, emerged, is the importance of how are you really setting the research agenda, and who is really setting the research agenda? What are the questions that are being asked? Are these relevant questions? And how do we center marginalized communities? How do we center people with lived experiences in some of this work around research, advocacy on mental health and suicide prevention? And of course, there seems to be unanimous consensus that we really need to shift the power, the locus of power, to communities themselves and people with lived experiences to shape and inform these processes in collaboration with other stakeholders as well. So yeah, I think these are some of the key insights that have emerged, and I'd just like to end with something very interesting that Dr. Rochelle said right in the beginning of the keynote address, which was, how do we reimagine mental health, and the whole idea of moving away from binaries and always sort of moving away from just the paradigm of mental illness and to really look at mental health in terms of hope for the future. And really, this is what our conference sort of seeks to do, and especially today's theme, which was to change paradigms around mental health, is to really look at what is the roadmap ahead? How do we create hope for the future and create a system and an understanding of mental health, which is rooted in the ideas of rights, human rights, and justice, social justice for all. On that note, I'd just like to thank all of our speakers for taking the time out and being a part of this conference. Really added richly to the discussions and the discourse, and I think all of us are going back with a lot of insights, and I hope this will also inform the work that we're doing. And last but not the least, I must thank the people who've been behind the stage, who put this event together, starting with the organizing committee between the 4 organizations which have organized this conference. I'd also like to thank the technical team, Vijay Lakshmi, Mahendra, Sharanya, Vijay, Nagraj, and of course, all of the rapporteurs who've been very diligently noting the proceedings of the conference, which will be published subsequently. And I apologize if I've left out any other names, but sincere thank you to everybody who has helped in putting together the first day of this conference. We look forward to seeing you on the next day, which is I think on 7th December. The agenda has already been shared in the chat box, but you can always go to the website, the FMES website, and you will get the agenda there again. So thank you again. Good night. Have a great weekend, and thank you all for your participation.